I would like to begin by acknowledging the traditional custodians of the land on which we meet today and pay my respects to their elders past and present. Hello and a very warm welcome to the 2021 Medical Careers Virtual Expo. This event is jointly brought to you by the Australian Medical Association of Western Australia and the Postgraduate Medical Council of Western Australia. My name's Dean and this is Jasmine, and we're your 2021 JMO Forum co-chairs. We are really excited to bring to you the first virtual expo. We've had over 570 medical students and junior doctors register to attend, and we hope that this is a really innovative and interactive experience for everyone.
The Australian Medical Association and Postgraduate Medical Council of Western Australia would like to acknowledge the following sponsors for this evening. Our platinum sponsor is St John of God Healthcare. Our gold sponsor is the Western Australian General Practice Education and Training, and our silver sponsor is the Joondalup Health Campus. On behalf of medical students and junior doctors, we thank you for your continued support.
Over the next 2 evenings, we're going to be having panel discussions with representatives from the various specialty colleges. We're going to be asking questions about the training programs, the colleges, and we'd love for you to get involved too. Questions are welcome at any time and can be accessed through the Q&A buttons which should be on your screen. And we hope this results in a really fun, interactive and insightful evening into the training programs and colleges you're interested in.
Recordings of the panel discussions will be hosted on the event platform you're watching through until late May. Following this, the Postgraduate Medical Council of Western Australia will be using the recordings to create a careers portal for you all to access throughout the year. Routine information such as training position numbers, application dates, and accredited specialty training hospitals will be available on this event portal under the Documents tab, and then on the Postgraduate Medical Council of Western Australia website. The busy lineup of colleges this evening includes the Royal Australian College of Physicians, the Royal Australasian College of Medical Administrators, and the Royal Australian College of General Practitioners.
So please sit back, enjoy, relax this evening that we've got lined up for you. And to kick things off, we've got Dr. Ash Coxon, who's our keynote speaker. And she's a general practitioner and a certified career counsellor who's passionate about helping medical students and junior doctors with their career decision making. Let's welcome Asha.
Our programs at St John of God Healthcare provide a variety of opportunities for interns and other junior doctors to progress their medical careers. As a leading healthcare provider in Australia, we offer a variety of employment opportunities for doctors in training to progress their careers. You will learn from senior consultants, many who are leaders in their fields, and benefit from our dedicated teaching, training and research opportunities. With access to rotations in a variety of clinical areas, St John of God Healthcare offers a unique hands-on experience with high-quality training and supervision. I look forward to having you as part of the St John of God Healthcare team.
Hello everybody and welcome to the 2021 PMCWA and AMA Medical Career Virtual Series. My name is Dr. Ash Coxon and I'm a general practitioner, career development practitioner, and I'm the founder and director of Medical Career Planning, which is a career planning and counselling service for medical students and doctors. I'd like to begin by thanking the PMCWA and the AMA for inviting me to speak to you all today about medical career planning, and also thank them for putting on such an amazing event for all the junior doctors and medical students of Western Australia. I'd like to acknowledge the traditional custodians on the land on which I'm on, which is the Bindal and Wulkurukaba people, and pay my respects to their elders past, present and emerging. So, how exciting, a virtual career series. Who would have thought years ago that we would have turned around and be doing virtual career series in 2021? But you know what? Here it is. It's very exciting. And I know that the PMCWA and the AMA have made this series as wonderful as they possibly can in the virtual environment. And I know you're all going to love this series. As I said, I'm a career development practitioner, and with the work that I do with doctors and medical students, I've learned lots of insights over the years about what doctors and medical students often wish they knew before they started their career journey. So I spend a lot of time talking to people who aren't really sure what they want to do or are early in their careers and don't have all of the knowledge available on what career to choose. And I also speak to people who are further on down their career journey and wish they'd chosen something else or wish they'd thought about other things before they made their definite career choice. So what I'm going to do with you today is take you through some of these tips and tricks that I've learned over the years from other doctors and what they wish they'd known at the start of their career journey. I hope you enjoy my talk today and good luck with your career planning. So the first thing I want to say to you is opportunity. You guys have the most amazing opportunity ahead of you. The career series that you're about to be exposed to is going to highlight so many wonderful medical careers out there, and there really are so many opportunities for doctors. It's really important though, as you go through this career series and even in your career planning, to understand that there are many medical careers out there and to increase your knowledge around these medical careers. One of the common things I do see as a career development practitioner is doctors who have chosen a pathway who said, I no longer like it, but I had no idea about all of the opportunities out there for me before I made this choice. Had I known all of the opportunities and all of the careers I could have trained in, I might have done something different. So if you aren't planning on attending all of these, watching all of the series as you go through this career series, I'd strongly encourage you to go to every talk, learn about every career out there, and to let it sink in and to know that maybe one day you might need this knowledge. Even if you're quite convinced you're going to do one pathway, you might need to know about all the other pathways out there. Inquire. Ask questions. If someone offers to speak to you about their career, take them up on that. One of the best things to do is to ask people who have done that specialty about that specialty. What do you like about it? What don't you like about it? And what do you wish you'd known before you started training? You'll find the most fascinating answers, which are going to help you figure out if that's the career you want to do. And network. Please ask questions, talk to people. As I said, ask them about their career. You might find yourself standing next to a forensic pathologist at a dinner function, or you might find yourself sitting down next to a medical administrator at a conference and you've never even heard of that career. If you haven't heard of a medical career, please ask them, what do you do? What do you like about it? And what don't you like about it? They're the key questions I think are very important to ask. So probably one of the most important things to do is knowledge and know about what medical careers are out there for you. How can you possibly know that you're absolutely sure that this one career is perfect for you if you don't know what else is out there for you? As I said, it's one of the really common things that people say to me, I wish I'd sat down and known about all those careers. So please, at the start of your career journey, find out all of the careers. There's actually over 80 specialties you can train in. That includes subspecialties, but over 80 specialties that the Medical Board of Australia recognises that you can specialise in. So don't just assume that you can only do the ones that you've been exposed to as a medical student. Sit down and learn about every career available. Where do you find the information? Well, your wonderful Postgraduate Medical Council of Western Australia has a very comprehensive website with all of the careers available for you to train in. It includes stuff such as workforce data, predictions about future jobs, who to contact if you're interested in talking about the job and what the job really is. So spend some time reading through that website, and things that you're really not sure that you might enjoy and you haven't heard about, or you've never even heard about this as a career, please spend some time sitting down investigating what that career actually is. The AMA also has an amazing information about what careers are out there, and I'd highly encourage you to go and look at their careers hub as well. Reflection. Reflection is the next part that's really important in your medical career. I know you guys are all good at it because you went through medical school, and I know that reflection is a very key component of medical school, and it is an important lifelong skill to have. Reflection is so important when you're trying to figure out what you want to do within your career, or if you're unhappy in your current career. So constantly asking yourself these things. What do I like about my current rotational situation? What don't I like about my current rotational situation? What do I like about medicine? What don't I like about medicine? And then once you've figured out those key things, are they modifiable or are they non-modifiable? So for instance, if you're really not enjoying your current job, and you sit there and think, well, what is it about my current job I'm not enjoying? Well, I'm doing after hours internal relief. I don't necessarily hate medicine. I just really don't like being on night shifts. Is that modifiable? Yes, of course it is. You're not going to be on night shifts forever, or you can choose to not go into a career that encourages or is all about night shifts. So once you can pinpoint exactly what it is you're not liking about your career, or what it is you do like about your career, you can start to then come up with a nice summary of things you're looking for in a medical career and try and find a career that satisfies that. The next thing, interests and skills. So important to know what your interests are and what your skills are, both inside of medicine and outside of medicine. So what do you like? Who are you? What do you like? What really interests you? What really makes you excited? Do you like knitting? Do you like painting? Do you like robotics? Do you like learning? Do you like studying? Do you like sport? What is it? Because once you know what really, really interests you, you can choose to actually try and tie that into your medical career. If you love robotics and if you love artificial intelligence, well, maybe heading towards an area like digital health or interventional radiology or areas that are really up to date with artificial intelligence is something that'll excite you. If you really love sport, maybe head down a sports physician pathway. But being very well aware of what your interests are keeps you really grounded in your medical career. And it also makes life outside of work lovely, that you have something else apart from medicine to keep you happy. What are your skills? So what are you actually good at? This is really important to also know for many reasons. Of course, you want to know what you're skilled at when it turns, when you want to apply for a job or apply for a training program, they're going to ask you, what are you good at and what are you skilled at? You need to know what your skills are. But more importantly, it's really great for self-confidence if you know what you're really good at. If you're kind of rocking that flow zone where you're really good at communication and you just get communication and, you're really wonderful at it, or you're a really good procedural operator and you're really good in surgery. It's really nice for you to know that, but it's also really nice to understand what those are, because you might construct a career pathway to head towards an area in which you are really skilled. Your values. Hugely important knowing what your core values are. If you don't know what your core values are, I urge you, this is probably one of the main things to do after this talk, is go away and find out what they are. What is a core value? A core value is who you are. What means a lot to you? What really deep down is what you really stand for. That is what a core value is. Is it ethics? Is it knowledge? Is it time and freedom? Is it family and friends? Is it intellectual satisfaction? Is it income? It's really important to know what is most important to you in your core values, because at the end of the day, moving towards a career that satisfies your core values is ultimately going to keep you happy in your career for a long term. If you find yourself working in an area or for an organisation that fits your values, you're going to be happy. If you find yourself in an organisation that doesn't fit your values, there's always going to be something that doesn't feel right. So please go away and learn what they are if you don't know. If you do know what they are, write them up, put them on a sticky note on your wall, and always remind yourself of what's really important to you. Your personality trait is also really important to understand, and I do lots of work with people around personality traits, and Myers-Briggs personality trait is something that I work a lot with, but any personality trait testing is important to know about and to understand that there are certain influencing factors on why we do things that are sometimes out of our control. And a lot of the time it's your personality, which is your subconscious control of what we do. But it's important to understand this, that sometimes these are going to have some influencing factors on our medical career, and sometimes it's not always a good thing. Sometimes there are blind spots in our personality traits that we need to be aware of. For instance, a really common personality trait in doctors is called a sensing personality trait. And these are people who believe what they can see, touch, taste, feel. They're factual, they're analytical, they're organised, and they really, really, really like external validation. So what I mean by that is they like knowing that the answers to everything. They like to know numbers, they like to know facts, they like to have evidence around things, which is a very critical part of being a doctor, and it's what we're taught to do. But sensates sometimes in that personality trait can rely on external validation too much. So when they get told that they're good at something by someone else, or when they get a good assessment form, or when they perform really well at an end of year assignment or exam, they can get mixed up in thinking that because they did well at something, that means they should do that career. So if they did really well in their gastroenterology rotation, that means that they should become a gastroenterologist. And this is a really common trait in medicine, particularly if a sensate is also a judging person who likes to have life planned. If you're not careful, you can turn around and say, hey, I'm really good at this, and I want to plan my life to do this, and therefore I should do it. So you can see sometimes if you're not careful, your personality trait, particularly as a sensate, can sort of wipe out your strengths, your interests, and your values if you're not careful. So be aware of that trait in particular. Last but not least, one of the most beautiful theories I've ever come across is a theory of planned happenstance. And this is by someone called Dr. John Krumboltz, who's a career theorist. And he says that indecision is desirable and sensible as it allows the opportunity to benefit from unplanned events. So basically what that's saying is, if you don't know what you want to do, it's okay. Take this as a wonderful opportunity to learn, to seek, to inquire, to be curious, to look at all of the medical careers out there. Ask yourself, can I see myself in that career? Ask yourself, does that satisfy my interests? Does that satisfy my values? Will I be happy long-term in that? And remember, it's okay if you make a choice of a career that you don't want to do in 10 years' time. You can always change your mind. It's just, medicine is a journey. It takes a long time to get to the end, and I really want you to enjoy the journey. Know who you are, know your interests, and enjoy yourself as you go along. Thank you for listening today. Enjoy the career series. As I said, my name's Dr. Ash Coxon. I wish you the absolute best of luck in your career, and if you have any time anyone wants to speak to me, my contact details are below. Enjoy.
The GPs in regional WA are very skilled. They have, of course, their specialist GP training, which they do, which enables them to really have a broad knowledge base and to be able to treat the whole patient and the whole family.
So we kind of have a tiered system here, really. We have the emergency specialists as well as GPs, and they work side by side in the emergency department. And it works really well for patients because they get that continuity of care from general practice, and it's quite a different viewpoint from the general practitioners to an emergency consultant. So there's very different skill sets.
GPs are the medical lifeblood of small country towns. I'm a small town person, so I'd encourage them to be a GP in any small town throughout the country, and I think they fit into the community and love being part of the community. I think they'd find that a very rewarding pathway if that's the way they wish to go.
Good evening. I'm Dr. Oliver Venetachi from Perth Children's Hospital. I'm your host this evening for this general practice panel. As a reminder, can I ask, we welcome your comments and your questions. There's a Q&A box on your screen in front of you, and we'd strongly encourage you to use that and ask your questions as they come up. This evening I've got the pleasure of introducing our GP panel for you today. First I have Mr. Hamish Milne from the Royal Australian College of General Practitioners. I have Ms. June Folds from the Australian College of Rural and Remote Medicine. I have Dr. Colleen Bradford from the WA General Practice Training, and Dr. Karen Pittman, representing the National Rural Generalist Pathway. Welcome to all of you, and thanks for joining us tonight.
Thank you.
So if you want to become a general practitioner, you can obtain your fellowship through either the Royal Australian College of General Practitioners, RACGP, or the Australasian College of Rural and Remote Medicine, ACRM. So Hamish, can I start with you? Firstly, for our viewers at home, why general practice?
I think that for doctors who want to have a patient-centred, comprehensive engagement with patients, general practice is certainly a real option for them. Whether it's acute care, complex care, chronic care, patients arrive all day, every day, from cradle to grave, and they have a range of problems that you'll have to investigate, use evidence base, and it's a really broad option.
Fantastic. And in terms of RACGP in particular, can you give our viewers at home some information about what it is that provides, the different pathways that it offers, and I guess what type of junior doctor you're looking for in your applicants.
The RACGP is a very large organisation across Australia, 40,000 odd members, with offices in every state to support our members, whether they're students, interns, residents, registrars, GPs in training, or in fact specialist general practitioners already. We do all the education and training for general practitioners, including their CPD, their ongoing CPD. We advocate strongly for the profession, and whether that's for Medicare rebates or other things. We're strong in advocacy as well. The kind of pathways that we offer, there are a standard fellowship of the Royal Australian College of GPs, the FRACGP, is a qualification that allows you to practice unsupervised in general practice anywhere in the country. That is done through the WAGPET training, AGPT path. We have people who come from overseas, they want to do the practice experience pathway. Some of those people will be specialists already overseas, so they'll be doing the specialist stream. Others who aren't already, they'll do the standard stream. People can do their training through the RVTS program, and there's also the rural generalism that's coming down the pipeline. So there's lots of options for people. I suppose I shouldn't forget the Fellowship in Advanced Rural General Practice, which is the extra year that allows you to have an advanced training in a particular skill to provide that slightly higher levels care in whether it's rural or remote, but it's also regional as well. I mean, we keep talking about rural and remote, but there's regional needs in regional Australia as well. The type of GPs, I suppose, that we want in those areas, for all those reasons that I said before, around wanting to be able to have a range of engagements with patients from cradle to grave, whether it's acute, the chronic, or the complex needs. So, yeah, that's the kind of person who would be interested in general practice.
Fantastic, Hamish. Thank you for that excellent overview. Can I ask, June, can I open up the same question to yourself? So from your perspective, why general practice?
I think variety. When you think that a GP sits in their practice and a lot of the time they don't know what's coming through that door. So they're switching their brains all the time from paediatrics to O&G to mental health. They really have to think on their feet. And the kind of doctor that I would like for ACRM is someone who is able to do that, who is committed to working in a rural area, to be part of a community, but also to have a range of skills that they can really turn their hand to anything that comes through the door. I mean, you imagine someone working in Halls Creek. They really have to be able to lead a team, traffic accident on the road. They just have to turn their hand to doing really anything that's expected of them at the time. So ACRM, as you will know, is the National Rural College and is very proud of the fact that it is rural and has been concentrating on rural doctors since day one. So ACRM has a national office in Brisbane, but are starting to become more involved in state operations as well. We will never get to the size of RACGP, but we are really starting to realise that ACRM members on the ground need good support. So the ACRM pathway, there's 4 pathways. There's the AGPT, and WAGPET deliver that program on ACRM's behalf in WA. ACRM is a 4-year program. So the minute you get into the ACRM pathway, you are thinking about rural. You are thinking about being a rural doctor. So the first year is you're back in the hospital. The second year, which I think is the exciting part about ACRM, is the AST, the Advanced Specialist Training. At this time, there are 13 choices of ASTs, and they range from palliative care to O&G, pediatrics, emergency medicine. The second year, the third year, right, actually, you are then back into the community. You're working in a hospital again. You're working in emergency. The fourth year is when you bring all your skills together and you are embedded in a community. You live there, you work there, and hopefully one day you will have such a good time that you will come back to that community. The second pathway is the independent pathway, And as that title suggests, these doctors want a bit of flexibility. They don't want to be locked into a 4-year structured program. They choose their own practice, they choose their own supervisor, but it's exactly the same curriculum as a GPT. The third way into ACRM is RVTS, Remote Vocational Training Scheme, and RVTS delegate those training programs down to the 2 colleges, ACRM or RACGP. So registrars actually choose which pathway they would like to go. The 4th pathway is the brand new one, still coming together, is the Rural Generalist pathway. And last year, the department gave ACRM 100 places per year for 4 years, RG training places, and that program is still being rolled out. COVID got in the way. It was meant to start in January, meant to start in July, but it's really watch this space, and this is the brand new ACRM approach to rural training. Thank you.
Thank you, Jean. Something that came across both of those was the RVTS program in both RACGP and ACRM. Can you tell me the specifics about that program and what sort of people would be applying for that one rather than perhaps one of the other pathways?
That's mainly for doctors who really want to practice remotely. And that's about, they could be working out in the islands, they could be in remote Aboriginal medical services. It's a distance education, supervision is done, what's the word, Colleen? Remote supervision.
Yeah.
So it's a little bit different, but there's a lot of hands-on by RVTS. They have regular face-to-face workshops, COVID permitting, of course, but it's slightly different in the way it's total remote supervision, and that brand of doctors really want to practice in very remote communities.
Okay.
It's an option quite a lot of practitioners who may have left the hospital system and embarked in general practice through a rural, like Rural Health West, remote locuming, may have been working for quite a while through another way where they get access to a provider number for general practice, choose to do RVTS. It's not taken up as much by the junior doctors because they're in quite a different place in their career.
Okay.
Yeah.
Thanks, Clem. So something that was common, I guess, to both of those comments from both Hamish and June was the importance of WAGPET in the training program here in Western Australia. So Colleen, I wonder if I can ask you, sort of from your perspective, why choose general practice as a career and what sort of importance does WAGPET to have in the training pathway here in WA?
So thank you, Oliver. So I always wanted to be a GP, so I chose general practice because I thought it would give me the ability to provide continuity of care to patients, as has been mentioned, which it has done. It's also extremely flexible, and it allows you to subspecialise and move into other areas of medicine which keep your interest in what you're doing from day to day. So as June has also mentioned, you may have an interest in obstetrics or emergency medicine, skin cancer medicine, so it allows you to dabble in another area as well as doing straightforward general practice, and for me that was medical education. It can also take you across the country and across the world. I've worked interstate and I've worked internationally, so it opens a lot of doors for a career as a general practitioner if you're a junior doctor. So to try and explain what WAGPET does, I thought the easiest way to explain it to the junior doctors is to relate it to your postgraduate medical education units in the hospital. WAGPET is a company that actually participates in the accreditation of all the posts that you will undertake, both the hospital-based posts, the posts in general practice. We assist and participate in the selection of the junior doctors that are coming into the general practice training program. We provide education and we employ the medical educators that work with you to deliver the education directly to you with workshops. We are also involved in contracting the general practices where you will work when you're doing your community time. And we have contracts with the general practices to make sure that they provide the appropriate supervision and training that you need to undertake. When things go awry, we provide backup support with our program training advisors, our regional program managers and our managers within the central WAGPET office, and we have myself as a clinical director of training. We have clinical leads of program support who can also provide you additional assistance in remediation and extra education, and we have other clinical leads that look after our assessment program and the overall education program. We do all of this to make sure that everything meets the standards of both RACGP and ACRM, and you can actually do both programs if you wish. It's a lot of work, but it is definitely open to you. Otherwise, when you apply to enter GP training, you nominate and you actually apply directly to the college that you wish to train with and fulfil their curriculum requirements. The actual round 1 applications for GP training have closed for this year, but the round 2 applications for ACRM will be opening later in this year, and I've got the dates in front of me to make sure I got them correct for everybody. So the 9th of August they will open, and they will close on the 30th of August, and the outcomes will be known by the 26th of November. For the RACGP round 2 applications will be opening on the 30th of August and will be closing on the 21st of September, and you will know whether you're successful by the 10th of December. So if you haven't already applied, there is still another opportunity to apply for GP training later in the year. And the other thing I would like to briefly mention, which has got a lot to do with junior doctors and GP training, is the GP project that the Office of the Chief Medical Officer has been working with WAGPET and all of your primary employing health services to pull together a suite of rotations that are really relevant for you to undertake to get a broad breadth of experience whilst you're in the hospital system before you decide to go into general practice or even any other specialty. So if you haven't told your hospital that you're interested in GP, or if you haven't told them that you're already in general practice training, please let your medical administration know, and they can help you to come onto the GP pilot with us so that you do get a broad breadth of experience before you move out into the community-based practice or the more challenging rural type of placements, which I think Karen is actually going to expand on quite soon.
Thanks. That's fantastic. I am interested though, you mentioned that some people do both ACRM and the RACGP pathway.
Yes.
What are the benefits to doing both of them, and what suggestions would you make to people about that?
Okay. So the benefits of doing both is you are going to get a very challenging and very, very rewarding career. It is hard to find the right balance. You will have to do most of your training out in the rural area, which is why we have our Rural Generalist Coordination Unit working with us to help those practitioners who do want to do that. If you have to do any Perth-based work, make sure when you are doing your rotations in the hospital, you really cover those core things such as the paediatrics, emergency medicine, your internal medicine, surgery, your anaesthetics, if not anaesthetics, ICU type of experience, leave relief, working nights, making sure you develop a bit of autonomy and responsibility, and then have a good think about what you want to do as your advanced career. It can always be in community-based medicine, in Aboriginal health, population health, mental health, and those sorts of disciplines, or it can be more of an emergency-based hospitalist type of discipline. It is a lot of work with all the assessments, and you'll take a little bit of time to work out when you're going to do your assessments at what point. And of course it does cost a little bit more because you do have to pay for the assessments, but it's very, very rewarding to do both. So we don't have very many, but we certainly appreciate those that do both colleges training, and we try and support them as much as we can.
Thank you. Karen, I might bring you in here. So for those interested in the Rural Generalist pathway, Dr. Karen Pittman is joining us here from WACS. I wonder if you can tell the viewers at home a little bit about how great it is working rurally, and also specifically about the National Rural Generalist pathway.
Thanks, Oliver. So the National Rural Generalist pathway was established last year, and the coordination unit in WA is based at WA Country Health Service, which is one of the main employers for rural sites around the state. A rural generalist is somebody who has skills in community and general practice medicine with also emergency skills and an additional skill set. It's much like what June explained with the 13 different choices. Most people recognise that as emergency, obstetrics, anaesthetics, but also palliative care, internal medicine, mental health, just to name a few. So the coordination unit, we work with both the colleges, and if you come through the rural generalist pathway, you will end up with a fellowship in either ACRM or RACGP, or both, if you go that way. And we work closely with WAGPET to establish the training pathways for anyone who's interested in our country sites. We certainly recognise that not all training can be done in our rural sites, and so we are certainly very aware to maintain the networks for anyone on the training pathway to be able to complete their needs of training, so that they can go and live and work in the community which is where they want to be established. We have mentors around the state who are all experienced rural generalists, and we are all there to work for you to try and get you onto the pathway and to the outcome with the career that you want.
Great. Great, thank you very much for that. I did want to ask a question to the panel about the independent pathway. It seems like is that a relatively popular pathway to take, or are there any downsides to doing the independent pathway?
It's interesting because the numbers are actually going up every year, and it's a whole variety of doctors who come onto this pathway. I'm finding I have a couple of specialists who have perhaps been a paediatrician for many years and suddenly would like to work with others than children. Mm-hmm. So I think it's growing more popular, I think, and I also think it's because there's a lot more support from ACRM than there used to be. The independent pathway doctor is supported by a training officer in Brisbane and also a medical educator on the ground, and then I do the pastoral care stuff on the ground in WA. But I do believe it's becoming more popular. Mm-hmm.
One thing to take note is the AGPT is actually free. That is provided by the government. Independent pathway usually is a personal cost from the practitioner, as well as paying for your assessments.
Okay.
Yeah. Can I just add to that?
Yes, yeah.
When you have an unstructured program, that's terrific in a sense, but you can also procrastinate. If you're not built into a structure, you can actually maybe take more time than you should to complete the independent pathway.
Okay. And just to be clear, WAGPET delivers all of the training for all 4 pathways, is that correct?
But the independent pathway is done by national ACRM.
Independent pathway, and the RVTS is still delivered by the Remote Vocational Training Scheme.
Okay, wonderful. I'm interested now in the application process. So when would you suggest that our viewers at home should be applying to get onto the training program? And I guess what is involved in that application that you mentioned before?
Yes, so each college actually has its own independent application pathway. So if you go on to either the ACRM or the RACGP website, it will give you information on when you are eligible. For our overseas trained doctors who might be listening this evening, it will take you down a flow chart to determine when you are eligible to apply. As I said, applications for this year, for round 1 this year, have closed. After that, each college requires some information about you. You need to provide are you still doing referee checks for ACRM? It might have changed.
I believe so.
Slightly. Mm-hmm. So they have an independent process. So ACRM will look at the referee checks and then organise and notify you on when the interviews are actually being held. So the RACGP also has a 2-step process. So you must sit the clinical and applied knowledge test for the next round of eligibility, and that will actually be held in Perth across the country on October the 20th and the 21st for anybody who's interested in round 2. And then following that, you must sit an interview as well. So at the moment, the interviews for both colleges for WA intake are being held at WAGPET, and we coordinate directly with the participants to organise the time and date that suits you to come along to interview. And then you get an offer through email, and you can decline or accept the offer depending on what you want to do from there.
And most commonly, would it be PGY1, PGY2?
Well, we are lucky because we've got the GP project. If you apply in PGY1 and you decide you really do want to do a PGY 2 and 3 year, you've got the opportunity to undertake that additional hospital year in Western Australia without any detriment to your training. So we've been granted an extra year. So the Chief Medical Officer worked with WAGPET and the colleges and the AGPT government to allow the doctors in WA to have that extra year. You can apply from PGY1, you can apply from PGY2. Some doctors we have PGY7, 8, 9, they might have done 5 years of orthopaedics and then they've decided to change direction. So, but you can apply from any time from PGY1 to come into GP training.
Okay,
yep.
Thank you. And Hamish and Ju, maybe I can ask you in terms of the flexibility that GP training offers in terms of part-time work and those types of things?
Well, yes, subject to anything Colleen says, all the colleges do have part-time programs.
Yes.
Yeah. Increasing flexibility in that area.
Yeah. Okay. For Colleen and Karen, actually, I had another question for you. If I was a medical student or an intern at home at the moment watching and still not sure that I wanted to do general practice, what sort of attributes in my own practice or in my own personality do you think I would notice in myself that would say, yes, GP is what I want to do?
That could be really interesting. We need lots of different types of GPs.
Yeah. So obviously you're never quite sure what comes through the door. So if you're prepared for surprise, then that's one thing, and to be able to think on your feet. You have to learn very early in your career to make decisions for yourself, because once you've started GP training, you're in an office with you and your patient, and you don't necessarily have somebody standing next to you and behind you and in front of you with which to bounce ideas off. So certainly early decision-making skills is something that it becomes important. Lots of empathy and ability to have great communication skills, because you will meet people from all sorts of walks of life. It doesn't really matter where your practice is, whether it's rural or metro. It's the ability to be able to interact with people from any age with any kind of issue and problem, and know how to recognise what needs to be sent further or not.
And deal with uncertainty. Be prepared to have seen a patient and not know exactly what's going on. You won't always be able to put a band-aid on the problem on the day that you see them. You're going to need to use your clinical reasoning, work out what to do next, organise follow-up and bring them back. So if you enjoy that as a challenge, GP will be for you.
Great.
And also, if you enjoy being part of your community, you know, you don't look after a patient, you usually end up looking after their family. And if you work long enough in a certain area, be it rural or metro, you'll get to know that person much more than just the patient sitting in front of you, but their family, their contacts, their friends, their interests. So that certainly gives you a really nice sense of community, and being able to give back to community is something really valuable. And if that's something that is important to you, then that's certainly well worth a consideration as general practice.
Brilliant. Thank you so much for that. I think there's been a fantastic amount of information given tonight, and hopefully at home people now have a clearer understanding of the different types of GP training pathways and the options that are available for them. So I'd like to thank the four of you for coming on tonight and giving up your time to help people at home make this decision. I'd encourage you all to please give some feedback on the panel on your screen now, and we'll close the panel. Thank you.
Our GP stream provides a variety of opportunities to kickstart your GP career. You will learn from senior consultants, many who are leaders in their fields, and benefit from our dedicated teaching, training and research opportunities.
Well, I'm looking at training as a GP, so for us having such a good access to the paediatrics and for obs and gynae and psychiatry and rotations like that is a really good foundation.
I wanted to be a GP in my future, so when I told them, they offered me rotations that are suitable for general practice, so I'm very happy with that.
I think it's vital for GPs to have a broad range in my specialties, and having had that opportunity to see a multitude of different patient presentations, from being present at the births of babies, doing baby checks, right through the gamut of having the absolute privilege of being with someone at their end of days and symptomatic control, and being able to support that patient and also their families.
Hi, welcome back. I'm Dr. Oliver Venetachi from Perth Children's Hospital. Tonight we're hosting a Doctors in Training GP session. I remind you all to, there's a Q&A button on your screen. We welcome your questions from home, so please feel free to comment. We're very privileged tonight to have three of our GP Doctors in Training joining us. They're all from WAGPED and they're all at different stages in their fellowship. So Dr. Anthony Rengel, he's actually got his fellowship with the Australian College of Rural and Remote Medicine. Dr. Anastasia Izakova, she's a doctor working towards her fellowship with the Royal Australian College of General Practitioners. And Dr. Matthew Pooley kindly joins us tonight, who's working towards an RAC GP fellowship, plus a fellowship in Advanced Rural GP. So thank you all, and thank you for joining us tonight. Can I start by asking each of you individually, perhaps Matthew, we'll start with you. Can you give an overview of your GP training program and why it is that that program in particular suited you?
Yeah, sure. So I've actually done the RAC GP training program and achieved my fellowship about 12 months ago, and I'm now coming to the end of the fellowship in Advanced Rural General Practice that you mentioned, which takes about 12 months. So coming to the end of that now. It's been and throughout that training program, I suppose I've done a mixture of metropolitan private practice, rural private practice, remote work, throughout the Kimberley, which has been extremely varied and very exciting and quite an adventure and a really great learning experience. So I suppose the variety's really suited me. That would be one thing. Yeah.
That's great. Yeah, fantastic. Anthony, can I pose the same question to you? So can you tell us a bit about your GP training program and what it was in particular that attracted you to it?
Sure. So I'm a fellow of the Australian College of Rural Remote Medicine, but I initially started off my journey by also being on the training pathway with RACGP as well. So I was lucky that during my medical school years and my intern year, I had some great exposure to rural medicine, and actually encouraged me to take the plunge and go do my training rurally. I started off working up in Geraldton, where I did the first 2 years of my training up there before I moved down south to finish off my training with Advanced Skill in Emergency Medicine. Part of the reason why I ended up going with ACREM, well, first of all, it combined a few of my interests and allowed me to bring in one of my hobbies into my work. I've also quite interested in aviation, and I'm a pilot, and I was able to use my flying to actually facilitate going out to remote communities as part of my GP training. And out there, I was able to experience some incredible medicine, seeing diseases which I hadn't seen or only read about in textbooks at medical school. So seeing things like leprosy and rheumatic heart disease, and being able to practice a really hands-on form of medicine. And most of all, bringing together skills from lots of different disciplines into my daily practice. And also, it's just a real fantastic group of people who work in rural medicine who are really passionate. So, yeah, that's part of why I've chosen to go with ACREM.
Great, thank you for that. And Anastasia, can I put that question to you as well? So why general practice, and what is it about your pathway that really resonated with yourself?
I think for me, I chose general practice because you need to know a little bit about everything, and I really like the breadth of the specialty as opposed to needing to go down really far into one thing. It's really nice being an advocate for patients, and that's why I initially started medicine, because to help as many people as you can in a variety of ways, not just fixing a wound or something else. There's so much more to it, social issues, other issues that can get missed by maybe a hospital system. So that's really quite fun. I did a lot of part-time work as well, so that was really important to have a training program that could facilitate that, because I was starting a family, so that was really important to me. And general practice really fit the bill there. Yeah.
Great. And have you stayed very much in an urban centre, or?
Yeah, so I do mainly older age care at the moment, and although you still get a lot of people coming in the doors from every walk of life, majority of my patients have been in nursing homes and older age, over 75. So that's more my subspecialty in general practice.
Yep. So if I can take you back to the decision that you made to be a general practitioner and to go through the FRA GP program, can you tell our viewers from home what it was that really made you choose that pathway rather than one of the other many options available in GP?
I guess I knew that I was going to remain in the metro area due to my husband's job not being very rural friendly, and because I had small kids, so that was really important to me at the time. I think you can go anywhere with the RAC GP, and should I end up eventually somewhere else, so somewhere rural, I know I can upskill, and I know that I can still go as a GP there. So it's still really flexible location-wise, and that's kind of nice.
Yep. And you did part of your training part-time, you were saying.
That's
How
right.
did you manage that? Did you find that you were well supported to do your training part-time?
Yeah, definitely. Look, I think it was a little bit more tricky initially, because a lot of these things weren't completely sorted out at the time, but now it's a lot more people are doing it, and it's a lot easier to navigate that, and a lot more tips and a lot more tricks to it. So that's been really nice to be able to know that I can be with family if I need to, and I can still have my career and be a really valuable GP if I need to. Yeah.
Excellent. And Anthony, can I come back to you in terms of when you were in the position of the people at home needing to decide what pathway to choose?
Yeah.
What was it about the ACRM program that really resonated with yourself?
Yeah, sure. So I had that unique experience having been on both pathways and working towards fellowship in both of them. And what resonated with me with the ACRM pathway is some of the requirements of experience you need to have to be an ACRM fellow. So both pathways, they will skill you up to be a highly skilled specialist primary healthcare physician, if we put it that way. GP can be described many ways, but that's how I think about it. Delivering good preventative health, family health, with special interests in different areas. With ACRM, considering some of the environments you work in, you're required to have a few extra special skills to deal with anything that can be thrown at you out there. So for example, you're required to do some training in obstetrics, you're required to do some surgical training, you're required to do anaesthesia, you're required to do emergency, you're required to have paediatrics experience. So there are a few extra things you have to do as part of your training with ACRM. And for me, I just felt for what I wanted to do, working remote areas, doing retrieval work, working in extreme environments, I felt that I needed to have that broad skill base in all those different areas to be able to do what I wanted to do. So that was part of the attraction. There's also some differences in the assessment, and this is getting down to some of the minutiae, but ACRM had very much a continuous assessment throughout the training program, whilst RACGP, a lot of the emphasis was placed on the final exams. Something that is changing going to the future, from what I understand. But for me, I felt the way that they did things kind of resonated with who I am as a person, what I wanted to achieve in my career.
Yep. And now that you've come out the other end of that, do you feel in practice you have been very well prepared for those paediatrics, O&G, those specifics of the program?
Look, I really do, and actually talking to the panellists just before I came on, we're talking about some of the scenarios experienced in our training, and I look back at when I was a registrar out at some of the remote clinics and some of the really curly things that came in, and like an anaphylactic shock who almost arrested on me, a patient in acute pulmonary edema. And look, I did manage them, I got the patients to where they need, but I look at what I was like then and compared to now, and my heart probably went to skip a beat now, being able to do it. And I think some of those experiences did add to getting that confidence ability to do that. But I do truly feel like the program has adequately prepared me to do the work that I want to do.
Yep. And Matthew, would you say the same thing resonates with yourself with your program?
Look, I think there's obviously less of a focus on remote area sort of emergency medicine and so forth in the RACGP training program. And someone sort of asked why I chose that, wanting to go rural. I suppose the truth is I didn't expect that I would be working rurally initially. I envisaged that I'd be a metropolitan GP. I went and worked for 6 months in Broome in a private general practice and absolutely loved the rural work, and was sort of exposed a little bit to the remote community work and so forth up there, and then decided that I wanted to go sort of down that pathway, and absolutely loved it, and that's why I did the FAR GP, I suppose, which is sort of like RACGP's extended skills in rural and remote medicine, and that encompasses a little bit of upskilling in emergency medicine. That's one of the prerequisites, I suppose, of that advanced training. Yeah.
So it's nice to know that they can cross over and still do both. Yeah. And so you still felt well prepared for your work, despite doing the.
Look, at the end of, I'm coming to the end of the FAR GP, and I suppose so. Yeah.
Yeah. Okay. Yeah. Slightly different tack from the panel. I'd like to ask you 2 or 3 things that are really good about your job and what you're doing with your training. Anastasia, we'll start with you.
So, 2 or 3 things that I love. I love being able to have someone walk through the door and know what to do with them. I think that is the funnest bit once you get past exams and you've calmed down a little bit, knowing that it doesn't matter what it is, you know how to progress, and that's really cool. The other thing is it's always what I imagine medicine to be. So you have a little bit of everything, and that's really kind of a crossover from the first point, but that is nice to have a break from just dealing with a really intense situation, to have someone come in with their new baby or something like that, and you have so many parts of life that you see, so many different kind of highs and lows, and you can be there for those patients for a long time through a lot of problems. Yeah, it's just the fact that it's not too much of anything.
Yeah. No, that sounds good. And Anthony, can I change that now and ask you to flip the other way, 2 or 3 things that are not so good about GP?
Yeah, look, there are a lot of negative perceptions about what GP is, and I hope us talking today might remove some of those, but I have encountered in my training that there are some people, particularly of other specialties, who look down upon us, and particularly in the rural sphere where we're required to do obstetric work, anaesthetic work and emergency work without support from these specialties. And there's some people, particularly metro-based, who don't believe it's the role of the GP, but they're not willing to come out and do the work themselves. So I did encounter that a lot in my training, but that has given a lot of us a lot of encouragement to kind of get through that and show people that as specialists ourselves in rural health, that we are capable of dealing with these situations.
Yep. And Matthew, can I ask you, what is it that you wish you had have known prior to commencing your training that you can share with the people at home?
Yeah, just a couple of very practical things, probably particularly related to the RACGP program. There is a procedural skills logbook, which is a lot easier to get done whilst you're still in the hospital setting, particularly in ED. So make sure you sort of get that and start filling it out before you leave the hospital system. Just some prerequisites as well before you leave the hospital system. So you have to do a paediatrics term, and if you're sort of at the just make sure that the hospital system you work for can offer that, because some can't. Being adults only, they're probably the main things, and try and tee up the GP placements early. Yeah.
Okay. Yeah. One final question from home is the challenges of being a rural GP in a small community. I wonder whether Anthony or Matthew would like to address that in terms of your experience.
Yeah, look, I guess there's pros and cons to it. So being a small community, everyone knows each other. When there's times of crisis, everyone does rally around each other, but it doesn't necessarily give much privacy. But also some of the advantages of rural, it is a small community, do get to know everyone. And look, in my rural placement is where I met my wife. So there are some advantages to going out rural.
That's great. Matthew, did you have anything else to?
Look, I think for me it's mostly positives really. Yeah. I think I liked feeling like part of a community, looking after a small community of healthcare workers. We all knew each other, looking after a community.
Yeah,
I think very rewarding. You probably get that a little bit in Metro GP as well. You get patients who become your group of patients, and often people work close to home, so you might bump into them in the shopping centre. It's not as bad and intense as rural, but it definitely has a bit of a village feel, even in the metro area.
Yeah, and there are challenges around patient confidentiality and so forth. You just have to be aware of it and manage it, and I think it is manageable.
And you felt prepared for that through your training program?
Certainly receive sort of appropriate guidance from supervisors and so forth. Yeah.
Great. Okay. We're out of time, so we'll leave it there. I'd like to thank the panel for coming in tonight and for giving that really good sort of overview and personal experiences of your different training programs and showing the breadth of what you can do with your GP fellowship. I'd encourage you to provide some feedback, please, on the icon on your screen. Thank you very much.
My name is Dr. Michael Livingston. I am a rural generalist covering Ravensthorpe and Hopetown in Western Australia. My advanced specialist training is in emergency medicine. I also offer advanced skin cancer procedures. I also do immunotherapy locally, some chemotherapy agents, telehealth, and trying to deliver that cradle to grave care that is lacking in a rural setting. People think it's just stubbed toes and trivial things. It's not. It's collapsed lungs, it's massive rollovers, it's internal bleeding, it's big open fractures, it's real thinking on your feet work, and doing so in a very resource limited setting with a very small team. So we use everybody, even from the cleaner to front reception, to help log roll patients and achieve just as good care, I think, as they would get anywhere else for that initial resuscitation. I would say, well, why wouldn't you do it? I'd say because you variety, extends your scope of practice, it challenges you, it will put you in some very, very testing situations, but it keeps you fresh, it keeps you current, and with those outcomes, that fosters respect for the job, and you leave the job feeling you've actually made a difference.
Thanks so much, guys. Yeah, I'm really sorry I was so rushed to start. I didn't realise we only had 50 seconds between the two, so had to run.
Hi, I'm James Caudle, and I'm the host for the dermatology panel. Here with me this evening is Dr. Kimball Opie from the Royal Australian College of Dermatologists. He's a consultant. Thank you, Dr. Opie, for being here with me this evening.
Thank you very much for the invite, James. The Australian College of Dermatologists reviews the actual training program.
Yep.
It's 4 years duration, and while there are 6 registrar positions, only a few come up each year.
Yep.
It's a 4-year training program, and it's Australia-based, so you apply Australia-wide, but then you nominate which state you prefer.
Yep.
Now it's hospital-based with rural placements, and there are options for PhD training as well.
So you just mentioned a minute ago that there's 6 places. Is that within WA or is that nationwide?
No, that's within Western Australia.
Yeah.
They are also can be part-time equivalents as well.
Nice. That's good to hear that the college is building in some part-time equivalents.
Very much so.
Do you offer any dual training with other colleges?
No, it's a standalone, but there are, after you've completed your exit exam, Mohs fellowships and cosmetic fellowships.
Okay. Yeah, good. And so what's the application process? So say if someone like me who's a junior doctor wanted to get into the program, how would we go about that?
It's applications in by January or February of the year after completing your PGY2.
Yep.
And then with that application, it's screened. So they're looking at academic, clinical, also your publications, and also outside experiences. And there's a bit of a focus now on people who want to do rural. The process, once you've applied, they close in April. It's screened, and then you go to a listing of suitable candidates onto interview, and then the states then select people in order of their application to the state.
And what sort of postgraduate year do people usually enter dermatology training in?
They can after PGY2, but vast majority, it's a number of years in after doing registrar work.
Okay. So you'd recommend that people spend some time in the hospital first?
Yes, it is a prerequisite. You have 2 years, but because of the competitive nature, lots of people are in their registrar years when they actually do get accepted.
And what are one or two of the good things about training?
It's a very small college, particularly in Western Australia, so it's a good fellowship. There's a lot of support, very structured, with continuous feedback as to your progress, and they've learnt from past experience a lot of support for the trainees.
Yeah.
Wide exposure in West Australia because you do travel between the hospitals. You aren't stuck in one hospital, so you get anything from paediatric to dermatology, and a lot of the consultants are interested in surgical work as well.
What would you advise is the best things to do? So you sort of explained that to get into the training there's a few things to buff up your CV, including rural. Is there other things that you'd recommend?
Definitely show your face. Talk to consultant dermatologists about any projects that they'd like you to perform as a research article. They do want you to have general med and general surg, but that goes without say. But there are resident positions that do include dermatology, but again they're very sought after. But if you're keen, you'll achieve it.
Is there anything, so you've been out of training for some time now, but is there anything that you would recommend people personally did before the training that you think would be helpful?
Yes. Get yourself known, so talk to the head of departments of each of the hospitals with regards to appropriateness of attending clinics. That's a good interface for you then to talk about research, because you want to have a very strong CV when you apply, and research does form a fairly strong part of that, showing that you're really interested in dermatology and following it as a career.
Yeah. Is there any downsides to being a dermatologist?
No, it's a good work-life balance, but as a registrar you do move between the hospitals throughout the day while having to sort of maintain inpatients and also fielding consults on the ward. So it is a very high kilometre training. After hours there are always tutorials as well, so you do have a little bit of a bite into personal time that way.
I suppose training's changed a little bit over the years, but do you think that it would be easy for people to move between the states? So we talked a lot about moving between the hospitals in WA, but if someone, say, wanted to transfer back to Melbourne or something for family reasons?
It can be difficult. I'm sure it can be done. You really need to almost do a swap, in that training positions in all states are very numbered and are very well sought after. So it can be difficult, but I'm sure there will be allowances made.
We talked a little bit before about how to get in and how to sort of improve your CV. That research that we spoke of, does that need to be dermatology based or?
Ideally it is, because you really want to show that you are that interested in the specialty. However, other based research would be considered, but not as much as if there is a dermatology bias to it.
And is all the sort of points for applying on the college website?
Yes, there's a step-by-step process that takes you through, and selection criteria.
Is there any more questions from our home audience? I can't quite read up there. And you sort of said your job was very flexible. Do you think it's a good job for someone with, who's looking towards having a young family?
Very much so. Recently a number of our junior consultants have gone off to have their family. It is part-time equivalents available in training, so you can have your family while you are training. It is, when you're a consultant, extremely family friendly with hours of your own.
Yeah. I know some other colleges are pushing for people to sort of match with someone else who wants the equivalent for the part-time, so say 0.5. Do you know if that's the case with College of Dermatology, or is it a bit more?
In previous years, when there's been someone who's gone part-time, then a training position comes up the following year as a part-time equivalent to fill that. Ideally, you'd like to have 2 part-time equivalents to fill the position, but no, there are part-time equivalents that come up in training that then can become full-time equivalents.
And exam-wise?
So there's no entry exam. It's based on your CV and your interview. Then there is the, as you go through, a pharmacology exam, but there isn't the exit exam, which is both written and clinical at the end of your 4th year.
Do you have to travel for that exam like some colleges? Or
Pre-COVID, yes.
Yeah, pre-COVID, yes, but now?
Now it's very much done in-house.
Excellent. Is there anything else you'd like to add about the college, or anything you feel we haven't discussed this evening?
Many people come up and say it's too difficult to get into, but I do stress if you are that passionate about doing it, you will get there. Admittedly, the success rate on first application is about 25%, but it does go up from there. And a number of people have come to me in previous times stating they were really keen but thought it was too difficult, and now training all our junior consultants. So I do really encourage people to pursue their desire.
Excellent. Well, thank you, Dr. Opie, for joining me this evening. I would encourage everybody to press the feedback button below for giving us feedback for this session. And I think we'll now go to an ad break. Thank you again, Dr. Opie.
Thanks for the invite, James. Thank you very much.
Hi, I'm Dr. Kate Needham from King Edward Memorial Hospital, and I'll be your host this evening for the psychiatry panel. So I'd like to remind you all that we welcome your questions on the screen by clicking the Q&A icon. I'd like to introduce our panel today. So joining us from the Royal Australian and New Zealand College of Psychiatrists is Dr. Mike Verhegen, who is a consultant liaison psychiatrist and also the Director of Postgraduate Training in Psychiatry in WA. I also have Dr. Natalie Schulman, who's an advanced trainee in psychiatry of old age. And also we have Dr. Wendy Newton, who's a first year trainee in psychiatry. So thank you everyone and welcome for your time. Thanks for your time this evening. Mike, I'd like to invite you to start, if you could, by telling us a bit more about the psychiatry training program.
Thanks, Kate. The psychiatry training program in WA is a 5-year training program that's broken up into 3 stages. So in a trainee's first stage of training, which lasts the first year, there is a focus on acute adult psychiatry. Subsequently, they go into the second stage of training, which is years 2 and 3, where the focus shifts to a few different subspecialty areas. And at this time, there are a couple of mandatory terms that every trainee has to do, particularly consultation liaison psychiatry and child psychiatry, and there's also the opportunity to do a couple of elective terms. Moving on to stage 3, which is the final 2 years of training, that gives trainees the opportunity to focus on a subspecialty area of their interest and do an advanced training certificate in one of those subspecialties. During the 5 years, there's a few exams that you have to do along the way, including a multiple choice exam, a couple of essays, and an OSCE exam, which is typically, for most trainees, done towards the end of 4th or 5th year. There's the opportunity to train in a couple of different locations. So most of our training is done in Perth, and there's no mandatory requirement for people to do any rural or remote training. However, there are the option of rural terms, if you like, in areas ranging from Broome to Albany. And there's also a recently developed opportunity to do a rural training program called the Integrated Rural Training Pipeline, which is a program where you do a full 3 years of your training in a rural area. So that's, I guess, a brief overview of the program.
Thanks, Mike. That was a great overview. I'd like to ask a few more broad questions now about life in psychiatry training or as a psychiatrist. So I'd invite you to, each of you, to give a couple of things that are good and some things that are not so good about training in psychiatry.
Sure. Well, I guess one of the good things for me is that it's a fairly broad generalist training program, which does give you experience in all areas of psychiatry, and it's also quite flexible. So it gives the opportunity to take breaks in training along the way, or train part-time if that's your preference, which can be really helpful for families. A lot of our trainees do take some time off along the way. I certainly did during my training, and it was one of the really good experiences that I had going through.
I have to pick just three. What I like most about psychiatry training is it's an absolutely fascinating career. There's so much complexity, and every patient is unique and has something different to offer the psychiatrist. I think in other areas of medicine, in surgery you might do one cholecystectomy after another, or in medicine treat one case of chest pain after another, but in psychiatry there's no mindless protocol or revolving door type situation. I think that every patient is unique and has something unique to offer the psychiatrist. I also really like the work-life balance that psychiatry has to offer. I think psychiatry is one of the fields where you're really actively encouraged to have interests outside of psychiatry training. I've always loved medicine, but I don't believe that that's all there is. I've always had interests in history and philosophy and ethics. And you're really actively encouraged to have other interests. As well as that, there are opportunities for part-time training or break-in training, and your own health and well-being and practicing self-care is really actively encouraged.
So I guess I can just tag on what they've said is absolutely true, and I found that myself. And just to add on to that, it's such a supportive training program. They do have the ability for part-time and full-time work, but also they have a great formal education program. Is it finished?
No, I think we're still going.
Oh, okay.
We're just changing to the question screen.
Sorry,
Thanks, Wendy.
So yeah, wonderful formal education program they have available.
Thank you all. That it sounds like a great training program, and you're even persuading me that maybe I should go and do psychiatry training. Maybe I'll direct this question to you, Wendy, given you've recently gotten onto the training program. How did you prepare yourself for getting onto the training program?
So firstly, like other training programs, getting experience in psychiatry was a big plus. So I did it as intern and as a resident. And then when I was considering to do psychiatry, I worked as a service registrar, and that allowed me to really try out being a trainee, knowing the roles and responsibilities and what I could expect in the training program, and that really prepared me. And also talking to trainees that were in psychiatry, and also the consultants about what is training like, and also about what is it like to be a consultant psychiatrist. That really prepared me to enter the training program.
Mike, do you have anything that you would add, looking at prospective applicants, what you'd really look for in a candidate?
Sure, and it is a competitive process to get into psychiatry training these days, where on average over the last couple of years we've had about 50 odd applicants for usually about 18 to 20 positions each year. It's possible to apply to enter psychiatry training straight out of your intern year, but given that it is competitive, it's more common for people to get into training in PGY 3 or thereabouts. It's really helpful to have an extra year of medical experience as an RMO following your internship, and it's probably most helpful of all, to have a little bit of time as a service registrar in psychiatry, which really demonstrates that you know what you're getting yourself into and you enjoy the work.
I've got a question coming through from the Q&A panel here asking if you have to do a lot of out-of-hours time or emergency time, for example, during your training?
I think it's very variable. It does depend on the rotation that you're doing. So the way it works in psychiatry is that every 6 months you will rotate. And this is wonderful in the sense that you get exposure to different services and different areas of psychiatry. But a lot of it does mean that the service requirements will change depending on where you're working. So in my first year in psychiatry training, when I was in the acute adult inpatient setting, it just so happened that I did have quite an onerous on-call or after hours. But in other rotations, there's been minimal or none. So unfortunately, it does very much vary.
Thank you. I'd also like to ask if there's any tips that you have for candidates who are listening about what they wish they knew or what you wish you knew prior to commencing training in psychiatry.
Well, to be honest, because I actively sought out experiences in psychiatry and talked to trainees and consultants, I really didn't have any big questions because I actually found out the information. But I think the most important thing is to go and try out, you know, to have more experience and see whether it might be something you like.
I would have to say the same. I'd had quite a bit of exposure to psychiatry before I got into the training program. So there weren't any sort of major surprises. I suppose it did surprise me that actually a lot of our work is in containment of both patient and staff anxiety, whether that's de-escalating an agitated patient or even containing staff anxiety on the medical wards, for instance. And I guess in order to fulfil that role, you also are required to have the ability to self-reflect and know what's going on for you in that moment in time. It can be very emotionally draining, I guess I could say, when you're dealing with an agitated or aggressive patient, for instance.
Thank you. I'd like to thank you all very much for your thoughts this evening. Just to wrap up the session, Mike, maybe I'll invite you to say in one sentence, if you can, what's the best thing about your job as a psychiatrist?
My job as a psychiatrist is a little bit hard to answer because I have multiple jobs as a psychiatrist with a combination of clinical work and education. And I really enjoy the flexibility and the ability to do different things with my career.
Thank you very much. That was great. Cheers.
The reason I picked St John of God, I really enjoyed the aspect of the close relationship one gets with the consultants and consultant level decision making and thought processes.
So it's a really supported environment. You really feel that you are part of the team and they will help you if you need it.
We have a well-developed teaching program and both formal and informal at the bedside.
I feel the education one gets in St John of God's healthcare is second to none, and it's led by some of the best specialists in the state.
And also because the teams are small, you get to step up pretty quickly as well.
Working in St John's of God gives me the opportunity to be able to experience all the rotations that are required towards my career.
I really recommend being a junior doctor at St John of God Healthcare for the teaching, the experience and the mentoring that you'll get at second to none, and you'll have a fantastic experience.
Hello, I'm Dr. Oliver Venetachi from Perth Children's Hospital. I'm your host this evening for this Defence Force panel. Just a reminder, we really strongly encourage questions from home and just use your Q&A button on your screen if you have anything you'd like to ask. Joining us today we have the privilege of Dr. Andy Robertson, who's the Department of Health Chief Health Officer and also a member of the Australian Defence Force. Thank you very much, Andy, for joining us tonight.
Thank you.
I'm going to have to suppress my internal desires to ask you about a certain virus at the moment and instead focus on the Defence Force program that you've come through with medicine. And your rank is a Commodore, is that correct?
That's correct.
and that's with the Australian Defence Force and the Royal Australian Navy.
That's correct.
So can you start by telling our viewers at home a little bit about the Defence Forces and about your training that you went through?
So I joined the Defence Force quite a while ago now, but as a medical student. I was a third-year medical student, and I completed my training with the Royal Australian Navy at the time, and I then did 2 years as in one of the hospital in New South Wales, did 2 years as a resident, and then went in full-time into the Defence Force. So the way that it works as an undergraduate is obviously they will pay for your time as an undergraduate, and then you have to repay at the end. But I trained then in general practice at the time, and then I stayed on in the Navy and subsequently trained in both public health medicine and in medical administration.
Okay. And in terms of generally applying through the Defence Force, what's the application program like?
So it depends a little bit where you're at in your career. So you could do what I did and apply as an undergraduate and have that sort of bonding arrangement. It's quite nice being paid as a medical student. Or you can come in as if you've done your first couple of years of training, you can come straight in as a direct entry officer, or you may want to join the reserve. So I did 20 odd years in the permanent forces, and then I joined the reserve and came in. And obviously in the reserve, depending on what background you have, then there's always a need for all kinds of specialisations. So, whether it's a surgeon or an anaesthetist, a critical care, emergency physician, any of those, a general practitioner, any of those are very keenly sought after skills that you can have in one of the three services.
Okay, thank you. And so as a third-year medical student applying to the Defence Force for your medical studies, what was it in particular about that training program that resonated with you and allowed you to go down that path?
Look, I think there's a number of things. One of the things was obviously interested in doing something a little bit different with my training. The military gave me the opportunity to do things that I probably wouldn't have normally done. As a young naval medical officer, I spent quite a lot of time at sea, visited quite a lot of, on ships, visiting different ports and putting your skills to use in those. But there's also lots of other opportunity to do that kind of work going forward.
Okay. And is there anything you can tell our viewers at home about what you wish you had have known about the Defence Force prior to you applying?
Look, I think there are, if you join as an undergraduate or a direct entry, there are a few things that you need to know. When I joined, there were some specialties you could do, general practice, obviously, public health, medical administration, sports physicians, you could train. But there wasn't really the scope to train in some of the, the surgical and related specialties. That has changed, so there is now opportunities for people to train in emergency medicine, in surgery, in anaesthetics, in orthopaedic surgery within the military. But that was a bit restricted when I first came in, but that you can now do that. But there are obviously specialties that you may be able to do in the reserve, but there's not a great demand for in the military. So, okay. For example, dermatology or rheumatology, it may not be the way to go. Okay.
And how would one find out about what is available and isn't available?
There's a lot of information on the defencejobs.gov.au website, or if you are interested, you can always talk to Defence Force Recruiting, and they have specialist health recruiters who can work through some of the challenges and and what's best suited for you.
Yep. I feel our viewers at home, sometimes your imagination can run wild when you think about the Defence Force and what it's like training there. Can you give us an example of a typical day in the Defence Force as a doctor?
Look, it depends on what you're doing at the time. So I've worked in as a general duties medical officer on board ships where we were looking after crews of a number of ships that were deployed overseas. I've worked as a weapons inspector in Iraq, from biological weapons inspections. I've worked as a public health physician on board one of the US Navy ships, Mercy, which is doing humanitarian work in Southeast Asia and the Southwest Pacific. So any of those could be, so there are lots of opportunities, and many of my colleagues have deployed to a whole range of different areas, including into places like East Timor, Afghanistan, Iraq, but also into humanitarian missions in Fiji, the Southwest Pacific, and a number of, Pakistan after the earthquake. Yep. So there's been a whole range of areas that they've deployed in.
And is that always a possibility that you could get deployed?
Oh, yeah, look, I think you have to assume if you go into the military that you will get asked to be deployed at some stage. And to be honest, most people do that because it gives them an opportunity to really use their skills and their expertise in different settings, often in more austere settings. So some of it is quite challenging. It certainly takes you out of your comfort zone at times, but it's also very rewarding.
Yeah. If I asked you what the best thing about that training program has been for you, and perhaps the worst or something not as good, could you give us those?
Look, I think the best thing is that there are lots of opportunities for to put it into good use, to put whatever your skills are, whatever your medical specialisation is, into good use to assist more broadly. So it's very different from a day, 9 to 5 day job. And I was reminded of one of my colleagues, a colonel who'd just come back from Rwanda, and he was talking to some of his classmates, at a reunion, and they were saying how, that they were just, they're finding it very hard to do the same thing every day, and he'd just come back from, really, assisting a great deal in Rwanda, and so there are opportunities to do something a bit out of the ordinary.
Yep. And as a last question, if you change your mind whilst you're on a training program with the Australian Defence Force, are there any commitments that trainees may have that they owe back to the...
It depends. If you're an undergraduate, if you go as a direct entry, no. So if you go in, if you're bonded, and I noticed there was a question about how long are you bonded for. It depends how many years they've paid you as a medical student. So it's usually whatever they've, if you do 2 years, it's 2 years plus 1. If it's 3 years or 4 years, then obviously a little more. But if you just go as a direct entry, you can come in for a set period of time.
Okay, fantastic. That's about our time for this evening. So I'd just like to thank Andy for coming in tonight and giving us your perspective on that. Thank everyone at home for everything, for joining in and for all your questions. Don't forget to provide us some feedback, please, with the panel on your screen now. Thank you.
Thank you.
Welcome to Royal Perth Hospital, a part of the Royal Perth Bentley Group. It is our privilege to be working on Whadjuk country, where we have served the community since 1829. As an inner city tertiary hospital and specialist trauma centre, we have one of the busiest emergency departments in the country. Our team of doctors take pride in delivering exceptional care in a high acuity, fast-paced environment. As an RPH doctor, you'll be well supported by the hospital's postgraduate education team and through a nationally recognised wellbeing program. Our well-established medical and surgical teaching programs will help you succeed on any career pathway. It's not all hard work. We have an on-site lap pool, gym, squash courts, the Milligans 150 Club, and of course the city at our doorstep. If you strive for excellence and want to serve the community of WA, we welcome you to join us and begin your career at Royal Perth Hospital.
Hi, I'm Dr. James Caudle, and this is our lovely representative from the Sports Medicine Australian College of Sport and Exercise Physicians, Dr. Arjun Rao. Thank you very much for being here with us this evening, Dr. Rao.
Pleasure, James, pleasure.
Do you want to just start off by telling us a little bit about the college and what's involved?
Certainly. So the Australasian College of Sport and Exercise Medicine is the preeminent professional body for sport and exercise medicine in Australasia. A 3-year foundation training followed by successful completion of the Part 1 examination and successful entry onto the clinical program results in a 4-year specialised training program in sport and exercise, with the aim primarily of training the individual to be skilled in a multidisciplinary team, to promote exercise and physical activity for health, and also to adapt its use safely in the management of chronic illness and disease.
Excellent, thanks for that brief overview. So you said the training program is 4 years long. Is there any exams during that 4-year process?
Yes, so as I already alluded to, before entry into the program there's the Part 1 examination, and then there's the 4-year period of training, and then there's the Part 2 examination at the end of that training, which is a combination of clinical assessment and written assessment too.
And so do people, how would they go about applying for that initial exam? Do they do the application for the college first, or do they complete the exam and then apply?
So as I alluded to, they have to do 3 years of basic training. The idea there is to get general experience in terms of a variety of medical specialties, after which, if they're interested in applying to our college, they can sit the Part 1. Once they've sat the Part 1, then they make the application. So they submit the CV once the Part 1 has been successfully completed.
And so you've sort of implied there that it's at least 3 years. On average, what's the sort of PGY level people apply to the college?
It's around about that period. We do get a few more mature individuals. Obviously, medicine's hard, and people often can chop and change, or they start a training program and they're not happy with it and they decide that they want to change to something else. But the majority are fairly driven and know what they want to do early on, and so they start pretty much at that 3 or 4 year post-graduation level.
Excellent. And what are a few good things about the training program that people can look forward to?
I would say probably one of the positive things about our college is the diversity of the clientele that we see. We see a huge range of people, both in terms of culture and age. I mean, I'll see patients in my clinical practice ranging from the age of 5 to 90, so you see quite a diverse group of subset of people. And it's good to be involved in a multidisciplinary team. Sport and exercise medicine is not something that you can perform on your own. You do need the help of a good team around you. So it's very analogous to actually being part of a sporting team, but obviously from a medical context.
Do people usually move around as part of the training program, or do they sort of situate in one spot?
So the trend in recent times has been for trainees to remain within their respective states. However, there is encouragement for people to either, if they're able to, transfer interstate, and there's also the opportunity to actually do part of the training overseas. We do have contacts over in Qatar at the Aspetar Sports Medicine Institute, for example, and various other places.
Excellent. Are there one or two things that are troublesome in the training, in the sense that people often struggle with, or?
Look, I think the main challenge of our training program, unlike the other colleges, is it's based in the private sector. So we don't have government funding in terms of our training. So the training is very reliant on the fellows of the college to provide it. And obviously, as individual practitioners, we have enormous demands on us, both in terms of our clinical work and also in terms of our administrative work, which is quite significant in this field. And the majority of us are in private practice, so essentially we're businessmen as well as clinicians.
Yeah. Are there subspecialties within sports medicine?
No, not at the moment. Yep. But we're still a relatively fledgling college, but as we've seen with orthopedics, where we've had generalists now moving into subspecialties, I think it's a matter of time before we're going to have subspecialty within sport and exercise medicine. But at the moment, we're still very much generalists and deal, with the body from the neck to the toe. And obviously, in terms of exercise prescription, deal with all sorts of chronic illness and people of various ages and so on.
So you'd say it's a growth industry then?
Very much so, and certainly with the public health directives, maybe not so much over here in Australia, but certainly in the UK in 2018, there was a huge public health directive in terms of exercise for chronic health. The Conservative government in the UK identified the problem of obesity and mental health, and I think we'll see fairly soon, once this pandemic settles, government directives of a similar ilk.
One of the questions that seems quite popular from our people at home is, what does a typical day look like for an exercise and sports science physician?
Well, I'm not sure there is a typical day because it varies quite a bit. So I would say there are 4 strings to my bow. There's obviously the clinical element where you're seeing patients and assessing them and managing them. That's one part of the day. There's an administrative element because you're running a business. As I said, you're running a private practice. There's also, if you're involved with teams, there's that component of it. So that might mean going to training or assessing players after training, or actually going to a match if it's match day. And there's also the research and education component, which is not just to our own registrars, but can also be to other specialties, for example, general practice and so on.
I just wanted to clarify one of your comments earlier about the trainee positions being in private practice. Are there any trainee positions in public hospital settings?
There aren't in WA. We used to have a position, it was a very long time ago, at the Royal Perth Rehabilitation Hospital, which no longer exists. It's been knocked down. But there aren't any public positions in WA. There may be a few interstate, but they're few and far between. Yeah.
And one of the other popular questions from home is sort of estimates of salary. Obviously not you personally, but comparative to other specialties.
In terms of registrar?
Yeah, well, I think more in terms of consultant, but consultant and registrar would be what I'm...
Well, we certainly don't earn as much as the orthopaedic surgeons, let's put it that way. But look, we earn enough to have a comfortable lifestyle. Let's leave it at that. And certainly the registrars are paid a lot better than we were when we went through the training program.
What things do you wish that registrars sort of knew before they got into training? What skill set would be particularly advantageous for them if they wanted to sort of move in towards this area?
Well, look, this might sound a little bit left of field, but I would say a good background and understanding in business would be very helpful, because a lot of your time is actually spent sort of planning your business and how you're going to move forward. So there is a non-medical element to your practice. It's not purely clinical work.
And one of the other popular questions from home seems to be, how does your role differ from a physiotherapist and orthopaedic surgeon? I feel orthopaedic surgery, we can sort of conclude with there's no knife involved, but physiotherapy, I suppose, is probably the better question. What's the difference there?
Well, the training's entirely different. I mean, we're trained from a medical perspective, and yes, there is a certain overlap in terms of musculoskeletal assessment and involvement, but we're coming from a specialist background as opposed. I don't want to be derogatory to the physiotherapy training program, but the diagnostic aspect of musculoskeletal conditions, from what I see in my clinical practice from physiotherapists, is somewhat lacking.
So difference in skill set then?
Yeah.
Yep. And how do you think people could best prepare themselves for getting onto the training program?
Well, number one, you have to have a really strong desire and heart for this profession. Your heart has to be 110% in it. It's a hard road. You have to make a decision, I think, fairly early on in terms of once you've finished your medical degree. And then I think you have to show some hunger. You need to you show initiative and try and learn as much as you can during that foundation training period. And once you've done that and you feel that it's the right thing for you, then go through the process that I've described earlier.
I might just try and sneak in one last quick question here, and that is, does the college help you find the rotations in private practice, or is that sort of up to the trainee themselves?
So if you're successful in terms of your application, the obligation is for the college to find you a position. So there's no need to worry. The issue is whether you get accepted onto the program or not.
Excellent. Sorry for the last couple of questions. We've sort of run out of time. But many thanks to
pleasure.
Dr. Rao for coming in and speaking with us tonight. Please click the feedback link below. And yes, thank you once again.
Thank you.
Thanks.
The reason I picked St John of God, I really enjoyed the aspect of the close relationship one gets with the consultants and consultant level decision making and thought processes.
So it's a really supported environment. You really feel that you are part of the team and they will help you if you need it.
We have a well-developed teaching program and both formal and informal at the bedside.
I feel the education one gets in St John of God's healthcare is second to none, and it's led by some of the best specialists in the state.
And also because the teams are small, you get to step up pretty quickly as well.
Working in St. John's of God gives me the opportunity to be able to experience all the rotations that are required towards my career.
I really recommend being a junior doctor at St John of God Healthcare for the teaching, the experience and the mentoring that you'll get at second to none, and you'll have a fantastic experience.
Hi, I'm Dr. Kate Needham from King Edward Memorial Hospital, and I'm going to be your panel host tonight for the Medical Administrator College. A reminder to you all that you're welcome to send any questions through at any time by clicking the Q&A icon on your screen. Joining us today from the Royal Australasian College of Medical Administrators is Dr. Sayanta Jana, who is also the National Medical Director of Silverchain. And we also have Dr. Gemma Bilkey, who's a Medical Administration Registrar working at the Department of Health. So thank you both for your time this evening and welcome. First of all, Sayanta, I'd like to invite you to start off the evening by please telling us a little bit more about the Medical Administration Training Program.
So Kate, thanks for this opportunity. As you know, the College of Medical Administration offers a 3-year training program. And as part of that, we encourage all graduates to come over and after at least 3 years of postgraduate clinical experience and then sign up for the college. There is now going to be only one standard pathway through the college. And if you got any previous experience in management, like a master's or anything like that, we would encourage you to apply for RPL, recognition of prior learning, as part of it. As part of the training program, you will go through some set tasks, management practice portfolios, research, and different scenarios and different work environments across public sector, private sector, health department, and the likes. And there is an unlimited scope in terms of where you can train as long as it's within the college training framework. But as part of it, we offer a really customizable training program, and that will really encourage your leadership skills. And end of the day, it's not about joining the dark side. It's about being, as I say, we are the guardians of the galaxy, and here the galaxy is basically the health system. And so we want to create change in the health system, and we want more and more doctors to sign up into the training program and lead the health system.
Yes, you certainly have a very important task to do. Gemma, I might direct the next question to you, given you're on the training program now. How did you prepare yourself to start the training program?
Well, it's actually quite interesting because I think the first thing I did was make a phone call to Sayanta to ask him about the training, about the job, and about what you could expect as a registrar. I think I, like many people in administration and medicine, didn't really understand what medical administration was. And at the time, I was, I guess, clinical medicine can be a little bit narrow in scope. I think, your world becomes medicine and that's it. And I really wanted to use my skills laterally, I think. And, in administration, you have the ability and the capacity to have to understand so many other aspects of life. So you really need to understand the political climate that you're working in. You need to understand economics. You need to understand ethics. You need to understand so many so many things. And so I was, I think, getting a little bit frustrated in medicine. Called up Sayanta and said, "Hey, Sayanta, what, talk me through this." And so I applied to do a master's because I think you have to have done or be doing a master's, and then I interviewed to get on the program.
Do either of you have any advice in terms of doing a master's? What kind of things are most relevant to the training program?
Yeah, so as part of the college, we prescribe a list of masters that are accredited for the training program, and that's published on the college website. And look, it's not really a hard and fast rule that you need to take on that particular list of masters. You can enroll in something of your liking. Usually it's a Masters of Health Management, Masters of Health Administration, or even could be an MBA. It just depends what you would like to embark on. And you have to realize an MBA, a full-on MBA, is much more labor intensive than doing a Masters of Health Management or Health Administration. Nevertheless, we all have different aims in life, and if you're ever going to be in a full-on environment where you want to be managing your own business consulting later on in your career as a medical leader, then absolutely no hesitation, I will encourage you to an MBA. So we do like to have that one-on-one discussion with our would-be trainees and give them some advice as to what sort of masters they would like to do, and then encourage them to talk to the National College and decide before they enroll into a program.
Fantastic, thank you. How many years of general medical, working as a doctor in a hospital, say, would you have to do before you can apply to training?
Usually, the college stipulates you need at least 3 years of post-intern or clinical experience that you need to get into the program. We usually suggest to our trainees that you should be aiming to at least have practiced as a clinical registrar, at least, because the main reason for that is you need to have that sort of a management vibe where you're managing your consultant, you're managing your interns and residents, and you know a bit of that management and that sort of test of your management skills. And that's when you realize, do I have it, what's in me to be a medical leader where I can make a change in not just one patient, but for an entire population? Let's talk about it. And that's what we do as part of this college. And then we invite them to join the training program.
A nice question coming through on our audience which relates to that is, do you still get to work clinically in your admin roles?
So many people do work either part-time or I know we have some trainees that spend some time doing full-time administration and then maybe do another year completing a different specialty. So there's certainly options to do dual training. I personally don't, because I'm quite happy in my role as a medical advisory role in the health department. But yes, you can. It's up to you.
On that note, we do have trainees who are training jointly in pediatrics and RACMA. We have trainees who are also signed up with College of GPs and RACMA. As long as both colleges can work collaboratively, it's possible, but you have to take into account this double the responsibilities and may require double the time to complete both the fellowships.
Okay, yeah, thank you. Would you both have anything to say on what are the good things about training versus the not so good things in medical administration training?
I love the variety of my work. I think having at the health department, I can't tell you this week what I'm going to have to understand and to manage next week. I think I love being able to solve really big, complex health system problems and the ability to be at the forefront of solving those problems. So I think that for me is the best part, is just the variety and the scale of what you can do. Also, as a registrar, I think you get so many opportunities to lead and to really make those changes. And I don't think you really get that in many other specialty training programs, is to get that really hands-on experience early.
And the not so good things, really hard to find for a training program like making medical leaders in the system. But the one thing I would probably say as a supervisor who has been supervising candidates for a long time is we do not usually give the same experience to every trainee who comes across. So it could be a combination of health department, public system, private system, community, and the next trainee who comes in could get a great tertiary hospital along with a secondary hospital. That sort of combination, but end of the day, we cater to a trainees' needs, their interests, and where they want to eventually train up as a medical leader, and that's what we work on.
I guess in many ways you could frame that as a positive as well, that the training's quite individualised.
Yes.
So just to wrap up the session, thank you to you both. I'd wonder if you could say in one sentence, what is the best thing about your job?
The best thing about my job is I get to create a change and be a leader in creating change in a system where this change is going to impact individuals, entire population for the next 100 years, if not more.
Thank you. And Gemma?
Absolutely agree with that. And just the variety. I mean, I've developed a niche in public health genomics. I've been able to publish papers. I've been able to take my interest and run with it. And I don't think there are many things that you can do like that.
Thank you both for your time. It was really interesting to learn more about the College of Medical Administrators.
Thank you.
Thanks.
Thank you.
The teaching I've received while working at WACS has really been second to none.
In rural sites you get really good foundational knowledge because a lot of the hospital stuff you're on generalised wards, not on specialist wards.
The teaching's a lot more personalised at WACS.
We get teaching every week, which is in person, it's really interactive.
So over the last 3 months I've managed to put in 3 arterial lines and a PICC line all up at Broome Hospital.
A lumbar puncture, putting in a chest tube and intubating patients in the first couple of years since leaving med school. The work-life balance is great. The workplace culture is just incredible. It's so easy to get help from everyone, including the nurses, the other doctors and the medical education officers. And it's the most exciting workplace I've ever been in.
If you want an exciting lifestyle and a rewarding career, then come and work for WACS.
Definitely do it.
This can help you grow as a practitioner way more than just being one of many on a team.
Do it.
I'm loving it.
Good evening, I'm Dr. Oliver Venetachi from Perth Children's Hospital. I'm here hosting tonight's panel with the specialist from addiction medicine. If I can just remind everyone, we welcome and encourage your questions from home. So there's a Q&A tab on your screen now, and if you'd like to participate and comment, we encourage you to do so. So we're privileged tonight to be joined by 2 colleagues from the Australasian chapter of addiction medicine. First, I'd like to introduce Adjunct Clinical Associate Professor Mike Christmas, who's a consultant in addiction medicine, and Dr. Gina Sherry, an advanced trainee in addiction medicine. Welcome to both of you, and thanks for joining us tonight. So perhaps if I can just ask a general question, Mike, maybe to you first. What is the addiction medicine training program and why would people consider it as a career?
Firstly, why would people consider it? It's a good specialty in that it covers a lot of areas that people might be interested in that won't be able to combine it in other fields. So for example, social work, a bit of psychiatry, medicine obviously, there's political elements to the field, there's public health elements to the field. So there's a lot of things that you can put your fingers into and get stuck into in this specialty. In terms of the training program, it's, as we've mentioned, it's under the RACP. It's a chapter program, not necessarily a divisional program. You can enter advanced training in addiction medicine 2 ways. One is through the divisional exams, so what we often call the first part exams, the clinical and written exams for the RACP, and then move on to advanced training as you would for other specialties. Or you can enter addiction medicine through having a primary fellowship in another area. For example, Gina and myself are both GPs. There's a number of different specialties that you can enter advanced training through.
Okay. And when you say a chapter, not a divisional part of the college, what do you mean by that?
So RACP have chapter programs, faculty programs and the divisional programs. So we're part of the chapter programs, which also include things like palliative care and sexual health.
And does that have any implication on the type of training or for the fellowship?
It does, in that you once you finish the training program, unless you do the divisional exams and enter advanced training through that pathway, if you enter through another, by having a primary fellowship in another specialty, you won't be able to use the post-nominals FRACP, so you won't be considered a physician.
Okay. And Gina, perhaps I can ask you a little bit more in depth about the training program itself. So from an example, what postgraduate level do people normally apply for the program? How long does it take and how competitive is it?
So I, as Mike had said, had done my GP fellowship, and most of the trainees in WA and most of the addiction specialists in WA have come through from a GP background or psychiatry background. The training program is a 3-year program, which in WA is through mainly Next Step, and there's 18 months of core training program and then 18 months of non-core training, which means that you have access to varying sort of subspecialty parts of addiction medicine, such as working in toxicology for a session or 2 sessions a week, experience at King Eddie's working with pregnant women who have got drug and alcohol issues, and also some time with public health and pain clinics.
And your non-core?
So the non-core is the sort of pain specialty, those types of things. You can go and do research areas which will count as your non-core training time, but for me it's going to be going out and working in separate areas.
Okay. And so Gina, in particular, what was it about this type of training program that really attracted you to it?
So my background obviously is general practice, and before that I worked in emergency medicine, so have had lots of exposure to alcohol and other sort of substance use issues, which is an area that I have enjoyed. As Mike said earlier, there's lots of social public health aspects, so it's something that we're coordinating our patients' care, and also sort of working within an important area with public health implications.
Great. Mike, perhaps you can tell people at home what you think the best 2 or 3 things are about the training program.
Sure, yes. I think it's flexible, so you can, as Jean has mentioned, you can do rotations in lots of different areas because lots of different areas are impacted by substance use disorder. So that's the first thing. The second thing is it's not particularly difficult to get into at the moment. It's one of the specialties that is accessible, I think, compared to lots of others. And thirdly, I think it's a very supportive environment at Next Step for trainees. The access to consultants and access to senior staff is pretty good comparatively.
What about from a work-life balance in terms of on-calls and hours of work?
Oh, look, it's. I think we'd all have to admit that it's pretty comfortable from a work-life balance. I mean, it's for most Next Step doctors, it's 9 to 5, no weekends, but there are. Yes, it's an on-call roster, which is not particularly taxing because we have about 18 different special doctors working, so it's not a particularly taxing on-call roster.
Yep. And Gina, in your opinion, the best 2 or 3 things about the program?
So I started the program in January. Certainly would agree with Mike that it's a very supportive environment. You can go and speak to any of the consultants or the senior registrar for advice and support. There's also case managers who are mainly nursing staff who also can help with sort of advice. Work-life balance is also very good, especially as I've not started on the on-call roster as of yet, but it's a job that I am really, really enjoying and finding a lot of satisfaction from doing.
Great. And if I can put the shoe on the other foot and say, and the worst things about the position, or not as attractive perhaps?
So obviously there's sometimes challenges with clients, like with everything, there's sometimes a few sort of political issues and things like that, but I think you know, we're sort of trying to work through those areas. And I think, you know, I have got a lot of experience. I've been a doctor for a long time, so that makes some of those challenges a little bit easier for me.
Yep. And what about job prospects once you've finished?
As things stand at the moment, as Mike said, addiction medicine is reasonably easy to get into, and as things stand at the moment, job prospects are looking pretty good within WA, with more addiction medicine consultant posts coming up, with funding, and also for registrar posts as well.
Okay. Oliver, can I just speak to that as
yes,
well,
of course,
please? Just a couple of the questions relating to future prospects. So firstly, once you've finished the chapter program, you have access to Medicare item numbers, so you can work in private practice in addiction, and there are at least 1 or 2 private practices in addiction in WA, and there's a number over east or in other states. And in terms of working at Next Step, is that the only option? Certainly most addiction doctors in Australia work for public services at the moment, but in the eastern states that involves hospitals, and in WA there's likely in the next few years that there will be consultant positions in addiction in the major hospitals as well.
Okay. Can I also ask, is there anything that either of you wished you knew before applying to getting onto the program that you now know?
I think the main thing is, unfortunately for our patients, they are marginalised, and I think the specialty in some ways over the years has been marginalised. So what we need now, and what is happening now, is to be integrated more into the health service, which is we're part of the Mental Health Commission at the moment. We're not actually part of WA Health, so to speak. But as I say, that transition is almost inevitable in the next few years, and consultant positions will be coming up in WA hospitals.
Okay. And Jenna, just to finish with, can I ask anything that you can suggest that people at home can do to buff up their CV, which would improve their application?
I think it's certainly a post that I found so far you do need sort of a wide experience coming into. So I would say would be sort of having general sort of, you know, resident posts through medicine, psychiatry, and also emergency medicine. Obviously a lot of us are GPs, so we get a lot of the broader experience from that training program as well. But it's something that is you can gain a lot of experience from.
Great, thank you. So Mike and Jenna, thank you very much for joining us tonight. It's a less heard of area of medicine, addiction medicine, but I think tonight we've had a couple of really good perspectives of the training program and the benefits of it. So thank you very much for joining us. Thank you for joining us at home, and we'd encourage you to provide some feedback with the button on your screen. Thank you.
The reason I picked St John of God, I really enjoyed the aspect of the close relationship one gets with the consultants and consultant level decision making and thought processes.
So it's a really supported environment. You really feel that you are part of the team, and they will help you if you need it.
We have a well-developed teaching program, and both formal and informal at the bedside.
I feel the education one gets in St John of God's healthcare is second to none, and it's led by some of the best specialists in the state.
And also because the teams are small, you get to step up pretty quickly as well.
Working in St John's of God gives me the opportunity to be able to experience all the rotations that are required towards my career.
I really recommend being a junior doctor at St John of God Healthcare for the teaching, the experience and the mentoring that you'll get at second to none, and you'll have a fantastic experience.
Evening, I'm Dr. James Caudle, and this is the Anaesthetists panel. Tonight with me I have Dr. Hannah Ray, an advanced trainee, and Dr. Jay Bruce, the Education Officer and Consultant Anaesthetist for Western Australia for the College of Anaesthetists. Thank you so much for coming, I really appreciate it. Would you guys just like to start by telling us a bit about your college?
Okay, so the Australian College of Anaesthetists accredits the training for anaesthetic trainees, and it's a 5-year training program. And then just talking a little bit about what happens with being an anaesthetist, you've got some clinical work that's involved that has both acute and longer term practice. We work as part of a very close-knit team that can change on a daily basis, and over time you can have team relationships that you develop over years. You work with your patients. You require really good communication skills with both of those groups. The patients, because you've got to develop a relationship in a short period, and the teams, because you've got to work with them under both calm and stressful conditions. It gives you a long-term career that has a lot of opportunities and flexibility in subspecialty areas, in pain management, and some people work and double train across ED and ICU. And long-term, as a clinician, you can have some choices about whether you work full-time or part-time, whether you work in the public or private sector. So there's a lot of options. It's interesting clinical work, there's practical components, there's a good theoretical component, and you have a really good broad range of knowledge about both anaesthesia, the general medical process, and conditions that patients have, and the whole surgical process.
Excellent. Thanks so much for that overview. Hannah, maybe I'll go to you. Can you tell us a little bit about the application process for getting onto training?
Yeah, so the application process will be coming out soon, in the next month or so. It involves writing selection criteria and a CV, and then if you get through that process, you're invited to interview, and that involves a question panel and also simulation exercises. Really, they're looking at, obviously, how much medical experience you've got in different areas and showing your interest in anaesthesia. But it's also about not just medical knowledge, but it's about human factors, so your kind of ability as a leader, a follower, situational awareness, and all those other things that make you a good anaesthetist and a good doctor.
Excellent. Dr. Bruce, may I just ask, what sort of PGY level do people usually enter college training?
Okay, the college says that you have to have done at least 2 years of PGY, of which at least 1 year has to be in non-critical care areas. So a year that doesn't include ICU, ED, anaesthesia. The rest of the time can be, we like you to have a broad range of experience. Most people enter somewhere between PGY 3 and PGY 5, but occasionally people change career late and have entered as late as PGY 9, 10 or 11. 3 to 5 is the most common.
And what are 2 or 3 good things about training?
For me?
Hannah?
Well, I think everything is good about anaesthetic training. You are very, very supported. You get given a contract every year, so you don't need to reapply. So for your 4 years of training before fellowship, it takes all the stress out of that process of having to get a job. They're guaranteed to get all your anaesthetic subspecialties like obstetrics, neuroanaesthesia through, so you don't have to worry about that. I've had parental leave and now work part-time, and I felt very supported in that by the college and the WA training committee. And just in general, anaesthetics is a great job. As Jay was saying earlier, you just get to work with great people. It's every day is different. Lots of procedural skills, lots of communication skills, working with patients at a really vulnerable time, where you can really have a good impact on kind of their hospital experience and their surgical experience. So yeah, lots and lots of great things about anaesthesia.
And Dr. Bruce, if I can ask you, what are some of the more challenging parts of the training program?
Probably the exams are the most challenging part of the training program. The first part exam has a big theoretical primary science-based component, and both of the exams require at least 9 to 12 months of a dedicated time to actually achieve a good pass rate. We have good pass rates for those exams in WA. There's a good supported system to get there, but it is hard work. And then probably the ability to take control and learn to be part of a system where there's critical decision making that can be quite confronting and challenging, and learning that process is probably of the clinical bits the most challenging part.
And Dr. Bruce, I might just refer the next question to you. That seems to be quite popular with our at-home viewers. Is it quite hard to do ED, ICU, anaesthesia, sort of dual training? Is it very common?
It's moderately common. There's probably within each year 1 to 2 people who come onto our training program who are doing dual training. It's long, I think. There's not a lot of at the moment crossover between the two training. There's a little bit. It adds a little bit. You might take a year off each at the most, so you would be doing up to 9 to 10 years to get there.
Okay, it's quite a long program.
It's a long program. You've got to want to do it. It gives good flexibility when you get there.
Hannah, I might just refer the next question to you. How competitive do people find it to try and get into anaesthesia training?
So I joined in 2017, interviewed in 2016, and it was competitive, but I had always been interested in anaesthesia and had things on my CV and had done simulation exercises, and I'd done a perioperative job, which there are a couple around in Perth at the moment. So yes, it is competitive. It's not as competitive as some surgical specialties, like ophthalmology, for example, in terms of numbers. But you've got to be really interested. You've got to know that you want to do anaesthetics. You've got to have shown on your CV and with what you've done in the past that you've really thought about this, that you're really committed, because like Joe was saying, the exams are a big commitment. Any kind of training program, you've got to commit to the end, and that's what they're really looking for, that you're interested and committed. So I don't know the numbers from the recent years, but yes, it's competitive, but it's still doable. Every year people get on. You've got 3 chances to apply, so 3 years in a row you can reapply, and you can use that time to make yourself a better candidate.
Excellent. Dr. Bruce, I might refer the next question to you. Job opportunities once people finish training, obviously it's a large commitment to go into training. Are there jobs available? What's the college expecting?
So we have looked at this at an Australian and WA-wide level, and the number of people who are training just about at the moment meets the expectation of ongoing positions coming available. There's been quite a big expansion in WA health in the last 5 to 10 years. So there's probably a good range of jobs available, and most people end up doing a little bit of public and private work. So there's also work available in the private sector.
Excellent. And I suppose just to finish off, because we only have a couple of minutes, Hannah, would you be able to tell us what a typical day sort of looks like for you as an anaesthetist trainee?
So it depends where you're working at the moment. I'm at King Edward, which is obviously obstetrics and gynae. But if you work in a general hospital, for example, Fiona Stanley, where they do a bit of everything, if you're doing an elective theatre list, that might be an orthopaedic all-day list, or I might do a morning of vascular surgery followed by an afternoon with the Met pager. A week at a time, I'll be doing the acute pain round with acute pain consultant and nurses. If you do the emergency list at a weekend, I could anaesthetise a 2-year-old and then a 99-year-old, do a labour epidural. I mean, this is what I like about it. It's so varied. But you'd still have the opportunity to do certain lists regularly so that you get to know the surgical teams, you get to know those kind of procedures. So I think it's very well managed at all the hospitals. You get a mix of the flexibility and the constant consistency.
If I may, Dr. Bruce, I'm just going to slide one last quick question in. It seems to be quite a popular one. What is the best way for people to prepare for the sim part of the interview? I'm sure that's something you get asked a lot.
We're looking for good clinical work at ward level. So thinking about what you do, what doesn't work and works well for you on your day-to-day clinical work, and when more urgent and met situations happen. Doing some ALS work is definitely worthwhile, and most hospitals have a simulation where there are access to other simulation processes, and it's worth getting familiar and comfortable with those. It won't necessarily be what you get on the day, but that will get you used to that environment. On the day, take it as a real situation.
Excellent. Look, I'm very sorry to people who've sent questions in from home because we're out of time, but many thanks to Dr. Bruce and Dr. Ray for coming and joining me this evening. Please click on the feedback link below to provide your feedback on this session so we can continue to improve. Thank you once again for coming.
Thank you for having us.
Thank you.
The reason I picked St John of God, I really enjoyed the aspect of the close relationship one gets with the consultants and consultant level decision making and thought processes.
So it's a really supported environment. You really feel that you are part of the team, and they will help you if you need it.
We have a well-developed teaching program, and both formal and informal at the bedside.
I feel the education one gets in St John of God's Healthcare is second to none, and it's led by some of the best specialists in the state.
And also because the teams are small, you get to step up pretty quickly as well.
Working in St. John's of God gives me the opportunity to be able to experience all the rotations that are required towards my career.
I really recommend being a junior doctor at St John of God Healthcare for the teaching, the experience and the mentoring that you'll get at second to none, and you'll have a fantastic experience.
Hi there, I'm Dr. Kate Needham from King Edward Memorial Hospital, and I'm your host this evening for the physicians panel. And just another reminder to you all that you're welcome to submit any questions that you have anytime by clicking on the Q&A icon on your screen. And also that after the session there will be some feedback that can go live, so please submit that for us to collect. I'd like to introduce you today our panel members joining us from the Royal Australasian College of Physicians. We have Dipen Sankesara, who's one of the advanced training registrars in cardiology. We have Helen Prince, Ms. Helen Prince, who's a member support officer with the college. And we also have Dr. Heather Lane, who's the Director of Physician Training and also a geriatrician at North Metro Health Service. So thank you all for being here this evening and welcome. So first, Heather, I'd like to direct the first question to you. Can you please start by giving us a bit of an overview about applying to basic training, physician training?
All right, so the process for applications usually starts about August of the year before, and around that time they'll be published on the MedJobs WA website, lots of information about the process. The first step is people need to have a job as an RMO or a registrar at one of the three tertiary hospitals in Perth, and then they can apply for physician training on top of that. There's a written application process with obviously a CV and selection criteria and some other information. And then from there we do go on to interview people. The process is exactly identical at all the hospital sites to try and keep it as fair as possible, and there's quite a number of people on the panel at each hospital involved in the selection process.
Thanks, Heather. And now, Helen, I'd just like to direct the next question to you. Could you give us a bit of an overview of the training scheme incorporating basic and advanced physicians training?
Certainly. So basic training is a minimum of 36 months of training. After a trainee has done 24 months of training, they're eligible to apply to sit the written exam. They need to pass the written exam in order to be eligible for the clinical exam. And then once they've passed the clinical exam and completed all the requirements for basic training, including the time requirements, then they've completed basic training. They then need to apply for advanced training. There are some 33 advanced training programs. Some trainees decide to generalise as well as specialise. They might do general and acute care medicine with something else. And if they do a single specialty program, it will be around about 3 years of training. If it's a joint program with something else, it might be 4 or 5 years for advanced training.
Thanks, Helen. It sounds like there's a huge amount of choice in the training program. So on that note, Dipen, how did you decide and go forward with your application process for becoming an advanced trainee in cardiology?
Yeah, so it's not an easy decision, I think, for a lot of people, I would say. And as Helen mentioned, there are about 33 advanced training programs to choose from, as you know, finish your basic training and things like that. It works for like different people, it works different ways. So for me, I kind of had an idea what sort of subspecialty I wanted to do. I wanted something that had mix of sort of surgical as well as medical skills involved in the and in the patient care. So I wanted to go something that involves a bit of theatre time, bit of procedural times, as well as clinical time. But there are lots of other specialties there which is mainly sort of clinic-based specialty, chronic care specialty. So think there's no right or wrong way how to choose it. A lot of people just do a few rotations in their internship and rotations and then get a feel of what sort of medicine they would like to practice going forward. And then they sort of consolidate their ideas and then come up with some sort of a plan for their rotations. I suggest before going into the exams, it's probably good to have an idea of what subspecialty you want to go towards, because you need to plan your rotations a year before your exams, because it becomes quite important. You have a good mentor and good sort of research going into the program and the exams, and that way you can apply for the advanced training just after clinical exams.
Thanks, Deepan. Is there anything you feel you wish you knew before applying to training, either basic or advanced training?
Well, I mean, I had done quite a lot of sort of rotations and research before going into the program, but things to know would be, I think, what sort of research is expected, what is the length of program, certain advanced training positions like hematology, they have exit exams. Some of the subspecialties may be bringing in exams. Helen might have a bit more idea about it going forward, but those sort of things is good to know. Requirement of the training also pretty good, I think, to know before going into the program, because it keeps updating every couple of years from college point of view.
Thanks, Deepan. On that note, Heather, we were talking a bit about this before. Do you have any advice to people who think they may want to do physicians training but don't quite know where they want to end up yet? Should they still apply?
Absolutely, because as Helen said, there's so many different pathways from basic physician training, and I think that's what's so good about physician training process in Australia, is you get such a broad kind of knowledge across all the specialties through your basic training that then you can take into your advanced training, because none of our patients really come to us with just one problem. So you've got the basic grounding and then you can specialise further, and you can, like Deepan, go for something really acute and interventional, or you can go for a specialty where you might be mainly based in outpatients. You can choose to be a generalist if you like a bit of everything and do something like general medicine, or you might want to become like super specialised in quite a narrow area, and you can do that too. And I think a lot of people come into basic training with one idea and then actually change their mind when they get experience of different specialties along the way. I certainly didn't know what I wanted to do when I started in basic training, so don't let that hold you back if you really enjoy seeing patients and your medical rotations as an intern in RMO.
Thanks, Heather. Now, Helen, we've got a lot of questions coming through from the audience about the application process. So a popular question is there a limit to the number of times that you can apply to basic physician training?
From the college's perspective, no, there's no limit to the number of times you can apply. Heather might be able to answer that, though.
In the WA process, there is no limit to the number of times you can apply. Once you're on basic training, there is a limit to the times you can sit the exams to progress to advanced training. So you need to really commit to the study and the hard work and get through those as quickly as possible.
What is the exam process like in the basic training?
So there's a written exam, so it's got two parts, a clinical part and a science part, and that does require quite a lot of study, but at each of the hospital sites there are lecture and education programs and written tutorials to help people through the exams, and the college has a huge bank of really high quality lectures online, and there's also courses as well that we try and get all the basic trainees to. So there's lots of support, so don't be put off because you don't feel confident about the exams, because there's lots of support there to help get you through them.
Thank you. And Helen, one of the other questions about training and applications is research essential to be considered for your application to physicians training?
It does help, research does help you with your efforts to get into basic training, but it's not essential. You can get in without research. Certainly you'll have to do some research in advanced training.
Thank you. Also, people are wondering about if you can only apply for basic physicians training if you're working at one of the big hospitals, or if you're in a regional setting, can you also apply?
At the moment, the process in WA is that you do need to be at one of the three main hospitals, but we certainly know there is a need for more training regionally and rurally, so that may change in the future.
Thank you. What are the things that junior doctors could do to make their applications more competitive for the BPT program?
So, I think, well, I guess the main thing is you want to actually take some time and put some effort into thinking about writing your selection criteria and your CV. It's definitely not a do the night before kind of a job. I think it's really helpful to get, find yourself some mentors, perhaps other people are on BPT or advanced trainees or consultants that you get along well with, and have a chat to them about your application and what to put on it. I guess what we're looking for when in the sort of interviews and processes is people who really enjoy and are passionate about physician and being a physician in medicine and working with patients or maybe academic medicine, and people who enjoy ongoing education, because that's what we need to do as physicians to keep up to date for the rest of our career. So we look at evidence for attending education sessions, and then if you've got some research or experience doing audit, that's sort of some extra icing you can add on the cake there to your application.
We've got a couple of questions coming through just about the interviews for physicians training. Is there any more information you can give about that? Specifically, they're asking about the MMI format. Apologies, I don't know that particular acronym, but what is the interview structure like, I guess, broadly?
So I don't know what that acronym means either. There's basically 5 stations, and each will be a question with 2 senior consultants or and often educators or college examiners. And I guess the focus isn't so much on like factual medical knowledge, because we know that you can all learn that, and we'll learn that through basic training. So we're looking more at those other physicianly qualities like teamwork and communication skills and those sorts of things in the interview.
Just in terms now, a bit of more about work-life balance. Some of the questions coming through about whether you're able to take time off in your training, whether you can take maternity or paternity leave during your training, and how flexible can it be?
Okay, give it a go. I think in terms of work-life balance, most of the training programs and departments are quite supportive. We know that in our current training group, we have a couple of people who have taken maternity leave during their program, during their advanced training program, and all the department and the college has been quite supportive of that. So I think that's definitely a yes from the college. In terms of work-life balance, look, some specialties will have lots of on-calls, and some specialties will have less of them. And that's just going to be a balance of things about what subspecialty you are going to be doing. That will decide. Something like cardiology, say neurology or gastrology will always have more on calls. But again, it's quite rewarding to learn during your on call, seeing the sick patients as well. So I wouldn't be put off by that.
Thank you. Any more to say about leave, maternity, flexibility, that sort of thing?
I'll just add that a trainee has 8 years to get through basic training with an extra 2 years of parental leave. A 3-year advanced training program, they'll have 8 years again to get through that with an extra 2 years of parental leave. If it's a 4-year advanced training course, it will be 10 years with an extra 2 years of parental leave.
Okay, so it sounds like there's a lot of scope for flexibility and tailoring it to your particular family needs. That's great. Somebody's just asked about finding a mentor, which you mentioned, Heather. Is there a way that the college can link you with a mentor, or how would you sort of give advice to people about finding mentors?
Well, I guess the first thing is, if you do find that you get on really well with someone you're working with, just don't be afraid to ask, because most people who work in hospitals are actually really keen to help and support people coming through. So don't be frightened to ask. I guess it's sort of a hospital-based thing. So I think going to your postgraduate medical education unit at your hospital site's a good place to start, and they can help find you a mentor.
Thank you. In terms of applying for training with your PGY year, there's a few people asking about what the timeline is, I guess, and if they've applied as an RMO, when do they sort of transition to registrar? So what year level can you apply, and then how do you transition to registrar, and what are the supports surrounding that?
So I guess people do apply from their intern year, so that's okay. People are more likely to be successful applying from their PGY 2 or PGY 3 year, because they've got a bit more experience. And again, it's quite individual depending on what year people enter when they might step up to being a registrar. Obviously, it's good to have some good registrar experience under your belt before you start applying for advanced training, so out the other end. And so you will probably think about timing stepping up to registrar around when you're sitting the exams as well, because you probably don't want to step up right on the exams, maybe a little bit before starting the exam. So we quite often have people step up from RMO to registrar partway through, either starting their second year or partway through their second year.
Thank you. In terms of the application process and finding the right referees, we know how important that can be. Do you have any suggestions for who the referees should be, if they should be physician consultants, or if they can be from other specialties or registrars?
I guess, if you're applying for physician training, physician consultants are good, but other specialties is absolutely fine as well. And an advanced trainee would be fine.
Thanks. Deepan, I might just direct a question to you as a cardiology advanced trainee. Would you be able to give a few things that you think are really good about the training pathway that you're on, as opposed to some of the things that maybe are some of the downsides to the training?
I think everything is great about cardiology, but to be frank, from my point of view, it's a good mix of sort of acute and chronic medicine. And it's got some procedural skill set involved as well. So that part of things I like a lot. I think that it's challenging, but it's at the same time it's simple as well, because you follow your physiological guidelines and things like that. So it's simple but complex, and it's mix of things. So I quite enjoy that kind of thing. I find it very rewarding, because most of the time you see instant results. It's especially in things like treating an acute myocardial infarction or tamponade or things like that. You see quick results, so you feel quite satisfying that you have been able to offer something to the patient straight away. But look, equally speaking, chronic medicine is the same. It's quite rewarding as you see your patients evolve from being quite sick to coming to achieving a good quality of life.
Thank you. It sounds like there's so many options available. One last question that we might have time for is about applying for basic physicians training with limited ARPA registration, or maybe for international medical graduates. Do you have any advice on that? Maybe Helen, you're the right person to answer.
You need to have general medical registration to apply, and you have to have done 1 year of internship as well. So they're the two prerequisites, and then to be accepted onto the program by the DP essentially of the hospital, and have a job at that hospital as well.
Okay. Somebody's just asking about how they get the approval of the DPE at each respective site. Any tips on that?
I mean, people come to me and say, oh, how do I get in? But the whole process is, there's a whole team involved with a panel reviewing all the written applications and a panel doing the marking. So although the DP is sort of responsible for looking after people at the end, it's a very standardised process, and as DPs we don't have we help with workforce to figure out what our capacity to train is, and then we take the best applicants from that process.
Thanks, Heather. Now that's time almost up. Just to wrap up the session, Heather, would you be able to just summarise in one sentence why you think physicians training is a great job?
I think what's great about physicians training is there's so much diversity in it, but that the pathway we have gives you a really good solid grounding across all areas of medicine before you move on into whatever area you find that you love along the way.
Thank you. Thank you very much to you all for your time this evening.
Thank you. Thank you.
Good evening. I'm Dr. Oliver Venataci from Perth Children's Hospital. This evening I had the pleasure of hosting our intensive care medicine panel. I'd like to introduce to you our panel. First, Dr. Michelle Ross-King, who's the chair of the KICM WA Regional Committee and a fellow of the college. And we also have Dr. Ashley Drury, who's an intensive care trainee. So welcome to both of you, and thanks for giving up your time tonight.
Thank you.
If I can start a general question perhaps to Michelle. Why intensive care medicine?
It's always a very complex question. I really do enjoy the intellectual pursuit of physiology and complex patients. I perhaps don't have the best attention span, and coming from a physician background, the most natural transition was into intensive care. And you will rarely meet an intensivist who doesn't thoroughly enjoy their job.
Yep. And perhaps specifically with the training program, Ashley, could you give us some of your experience in what it was like applying for the program, when you did apply, and what you did to buff up your CV?
Yeah, so I applied to KICM, the college, in my PGY 4 year. I had done a couple of terms as a resident in ICU, so I did a term at Hollywood and a term at Charlie's as a resident, and then I did the perioperative medicine job, and then I took on a service registrar job at Midland ICU, and then I decided to apply. In thinking about applying to ICU, in addition to doing those couple of terms, I think I really just engaged with a lot of the ICU physicians, and I did an audit project while I was at Charlie's as an RMO. And I did a couple of courses in critical care because I think I knew that I was headed in that direction.
And in terms of the length traditionally of the training program?
So it's roughly 6 years if you're efficient. So you do 2 years of core ICU and a year of transitional ICU, a year of anaesthetics, and then some medicine, some peds, some rural, and an elective. If you add it up and you are efficient about it, you can do it in 6 years. But typically it might take a little bit longer.
And Michelle, would it typically be a PGY 4 or 5 who applies for this program, or can you do it sooner?
Yes, we do have some trainees who come a little bit earlier, particularly with the COVID pandemic. We had quite a few registrars stepping up from PGY 3 into ICU registrar roles. I think that it's it was necessary at the time, but getting a broad background in general medicine, infectious diseases, cardiology, emergency medicine, really starting in PGY4 is probably the best.
Okay. And Ashley, have you found the training program user-friendly in terms of work-life balance, abilities to work part-time, have children, have a family?
Kickham's quite unique in that they don't organise your jobs for you, so you still have to seek out the specific jobs at each of the hospitals, although it is becoming a bit more centralised, the application process. In terms of work-life balance, I guess you know that you're committing yourself to a lifetime of largely shift work, and you will do really long hours, but then the caveat to that is that you'll get more days off. I guess I can only speak from experience. I've got one child at home who's a toddler. I'm currently working full-time and we're making it work, myself and my partner. But it is quite demanding, and I guess if you're willing to, you just have to know that you're going to be doing a lot of night shifts and shift work, I guess, for most of the rest of your life.
And most of the hospitals, the registrars, I would say, and particularly at Midland, we encourage registrars to have a good work-life balance. And one of those is seeking out 0.5 FTE positions. I would say that there's very few exceptions that don't offer some type of flexibility in that regard.
Okay. And Michelle, as the head of the local trainee committee, what are you looking for in a medical student or an intern coming through in the next couple of years in terms of their attributes for a good trainee on intensive care medicine?
Well, I would say, and I probably will embarrass Ashley, but Ashley really was the ideal trainee. So I will describe her. Very hardworking. She has always been very keen and very naturally curious about each patient and each patient interaction. Having that ability to have situational awareness and paying attention to your entire environment and not getting easily distracted is a very important skill for intensive care. And then there's the technical skills of putting in or doing our basic procedures. ICU is one of those great fields where whatever you bring to the field, you can use it, and then you'll learn more, in particular with procedures.
Okay, great. Ashley, can I ask you, if you had to pick a couple of things that maybe weren't so glamorous about the intensive care training program, what would you warn other people about?
So I guess I've spoken to the shift work already. There are two very big exams, and I know that exams aren't unique to Kickham, or all the colleges have very difficult exams. We have an exam that you sit at the very beginning and an exam that is typically an exit exam, and they do require a lot of study, typically around 9 to 12 months, and it is a challenging year to get through those exams. In addition to the shift work, I guess some of the things that you see in ICU can be quite challenging. We do a lot of end-of-life care, palliation, brain death testing, that kind of thing, organ donation, and I guess that kind of thing needs to interest you if you want to go into intensive care.
Yeah. And for potential applicants at home, in terms of buffing up their CV and their preparation for application to the program, some people do masters, research. Is there anything either of you can suggest in particular from an ICU perspective?
I think make sure that you want to do it. So do a couple of terms in it if you can in your PGY 2 and 3 and 4. You could get involved, show the units that you're keen by doing an audit or some kind of research. There are some courses that you could go on to see if it interests you, having your ALS 2, going on the basic course, or even ATLS might be advantageous. I think just showing that you're keen and getting involved.
And I would add to that specifically the basic course that's taught at most of the tertiaries, ALS 1 and 2 and the ATLS. There are ultrasound courses. Intensive care is increasingly becoming an ultrasound focused specialty. So learning to do fast scans, ultrasound guided vascular access, thoracic And a lot of these are offered across town. We're quite fortunate, despite being a bit of an isolated city, we have the ability to have CTEC in the community, Nexus, and lots of other programs that will give you the experience and the background to be a successful candidate.
Is there anything that you can share that you wish you had have known prior to get onto training?
I think you can be, if you really want to do it, you can be quite efficient in your RMO years, which I wasn't, but I didn't really know where I wanted to go. For example, you might do a rural term or a PEDS term, and then you might be able to get those recognised as prior learning once you do get onto KICM.
Could you do those, actually, as an intern? Or?
I think you can do, potentially not as a PGY1, but I certainly had a few of my RMO terms recognised as prior learning in terms of my general medicine and my elective term. It would have been nice to have done something rurally and had that recognised, or maybe some PEDS, whereas I'm now looking down needing to do that kind of stuff.
And when I talk to the trainees, the main concerns that they have are the dates. So KICM only has one intake per year for the trainees. This year it's the 31st of May for the first, I think, to request the application, and then the applications close, I think, at the end of July. So making sure that you get your time in and then lodge your application in a timely manner. We do have foundation units across town. Probably the most significant for me would be St. John of God Midland, but Armidale, and I think Hollywood.
I think you can do your foundation 6 months at most of the ICUs around town, but you'll certainly get a really good scope and breadth of practice if you go to one of the peripheral units, and they are more likely to take on a more junior service registrar because that's what they're set up to do, I guess. And so certainly I did Midland and some time at Armidale, and they were brilliant starting blocks for me.
Yes. Great. And then it allows that nice transition into the tertiaries.
Yep. Great. That's about all we've got time for tonight. So I think we've had a really good introduction there to the intensive care program and what it's like as a trainee and what sort of qualities we're looking for. So thank you both for your time tonight, Michelle and Ashley.
You're welcome.
And thank you at home for tuning in tonight and for the whole evening. Again, please leave some feedback which is on the button on your screen at the moment. And I remind you about tomorrow night, please come along. Again, we've got some excellent speakers and some colleges coming tomorrow night, all starting from 6. Thank you for your time tonight.